Hello, and welcome to the Health and Government Operations Committee. Some basic rules we like to go through at the top of every meeting. Please do not forward the Zoom link for the hearings. Staff will allow anyone who is not invited to testify, will not allow anyone who's not invited to testify into the hearing. But I do ask that you encourage people to watch the hearing on YouTube. The bill sponsor witness timing is as follows. The bill sponsor is allotted 5 minutes to present the bill, and 5 witnesses will each be allowed to speak for 2 minutes. And then after that, of course, opposition panels have the same rules, so they can also have 5 witnesses for 2 minutes. Please conclude your remarks when you see the timer finish. Members must remain present with their video camera on during the entirety of the hearing. And members, of course, we have these rules every day. Please ask only one question of one witness. And if you have other questions, you may follow up offline. And please use the raised hand function to indicate that you have a question. That makes it much easier for us to keep the questions in order of who raised their hand first. With that, we do have 9 bills today and 72 people signed up to testify. So we expect we'll probably take a break somewhere in the middle of this agenda. But the first bill is House Bill 731, which is an administration bill, telehealth services expansion. And I think our first person signed up to testify is Aaliyah Jones.
Delegate Kelly, is it okay if I go first and then I'll turn it over to?
Absolutely, Jake, please do.
Awesome. Thank you, Delegate Kelly. Madam Chair, Madam Vice Chair, members of the committee, my name is Jake Whitaker, and I'm here on behalf of the Governor's Legislative Office to testify in support of House Bill 731. Since taking office, the Governor and Lieutenant Governor have remained committed to addressing the heroin and opioid epidemic, including expanding access and reducing barriers to critical behavioral health and substance use disorder services. House Bill 731 expands access to these critical medical services by allowing healthcare practitioners to provide services via audio-only conversations like telephone calls. This bill will also require private carriers and the Maryland Medicaid program to reimburse for audio-only services. Allowing audio-only modalities like telephone calls will make it easier for practitioners to serve patients in underserved communities who may not have access to expensive audiovisual technologies. Additionally, this bill will also help Marylanders living in rural areas who may not have access to broadband services. This bill is an important next step in making healthcare, including mental health and substance use disorder services, available to all Marylanders. And for the aforementioned reasons, I respectfully request a favorable report on House Bill 731. And if okay with you, Delegate Kelly and Madam Chair, can I turn it over to Dr. Jones for the rest of my time?
Absolutely.
Great, thank you.
Good afternoon, and thank you for having me. I'm Dr. Aaliyah Jones, Deputy Secretary of the Behavioral Health Administration for the Maryland Department of Health. Can you hear me?
Yes.
With the COVID-19 pandemic, waivers have been introduced that have increased the use of telehealth, as we all know, and this includes the utilization of telephonic services. The data from the Administrative Services Administration showed that there has been a significant increase in the number of people who access mental health services using telehealth from 2019 to 2020, from 7,398 individuals in 2019 to 106,642 individuals in 2020. And this is for mental health services. The same increase in utilization is also seen on the substance use disorder treatment side, where we had 1,720 individuals who used telehealth in 2019 and 26,084 individuals in 2020. This increase in the use of telehealth services represents an increase in the use of the various mediums, including audio only. During this time of the pandemic, consumers of behavioral health services have wanted and needed to remain in care. In serial surveys conducted by the Behavioral Health Administration in the summer and fall of 2020, we saw a decrease in the number of people who were keeping fewer appointments, that decreased from 30% down to 22%. And the number of people who were keeping more appointments rose from 36 to 42%. The fact that 69% of providers felt people were keeping more appointments or about the same number of appointments as they were keeping in the early spring shows the power of telehealth to keep people engaged in care, treatment, and services. When asked about the successes that have been experienced by individuals in using telehealth, 73% of our respondents stated that because it eliminated the need to travel, and 69% said that it made treatment access easier. 55% of our respondents stated that patients were participating more in their care than they were when they were in face-to-face visits. The conclusion of all of this is that the shift that we've made to telehealth in the public behavioral health system, consumers have resoundingly responded in a positive way. They enjoyed the flexibility of receiving telehealth services, and providers are increasingly planning to use telehealth in the delivery of services. The Behavioral Health Administration licensing unit is currently seeing an increase in the number of providers stating they will be providing services via telehealth, including outpatient mental health clinics and substance use disorder treatment programs, all of which have and will result in an increase in convenience and access to behavioral health services during the pandemic and after. Let me say a word about what we're experiencing and what we're expecting to experience after this pandemic with regards to utilization of behavioral health services. Research from previous disasters indicates that behavioral health impacts tend to remain elevated for up to 2 years or longer post a disaster. This pandemic is an experience that the modern world has never experienced, so we can't really predict what will happen. However, we also can't ignore the fact that in 2020, we saw another peak in opioid overdoses across the country, including in the state of Maryland. The National Center for Health Statistics Household Pulse Survey in January showed that 32% of Marylanders were having symptoms of anxiety, and 27% were having symptoms of depression. 40% had symptoms of one or the other. Nationally, these symptoms are greatest in our youth and people ages 18 to 29 years old, which peaked at 51% in October and trended downward. The incidence decreased by age. Depression trends are similar, with a peak of 44% of our young people who were between the ages of 18 and 29 reporting symptoms of depression. These symptoms have been increasing in incidence since the early fall of 2020. And shockingly, at this moment, close to 60% of young people have symptoms of anxiety or depression. This bill would in effect provide for needed expansion of various mediums of telehealth used for providing services and codify various kinds of telehealth services currently being allowed, namely the audio-only expansion. A Kaiser Family Foundation study showed that in 2017, sizable shares of non-elderly adults with Medicaid reported that they had never used a computer. So this is in regards to the need for audio only. So this is 26%. They didn't use computers, 25% didn't have access to the internet, 40% did not use email. And a study by the Harvard School of Public Health showed that 21% of rural Americans reported that access to high-speed internet was a problem for them or their family. If audio only ceases to be an option for payment for treatment services, there will be an increase in disparity of access and outcomes for those who don't have access to or the ability to use these technologies. These people tend to be older, Black, from urban areas, or who were self-pay on Medicaid or Medicare payer status. Continuation of audio-only visits is essential to healthcare equity. As we roll this out, though, of course, we have to make sure that we're addressing any issues of quality as they might arise. In conclusion, the COVID pandemic has worsened the behavioral health crisis that we have always been in, with more people likely to need care to return to pre-COVID baselines or better. During a time such as this, we need to remove as many barriers to treatment access as we can so that we can reach and help as many people as we can. Only 43% of the United States adults with mental illness received treatment in 2019. 43%. It is without doubt that this legislation will help us to improve the number of people that we can reach for behavioral health care, treatment, and services, and we hope that it passes. For the aforementioned reasons, we respectfully request a favorable report from the committee on HB 731, and we would be happy to answer any questions.
Thank you, Dr. Jones. I believe we have one more panelist, Mandar Jadlav.
Yes, thank you. Good afternoon to the chair, vice chair, and honorable members of the committee. My name is Mandar Jadhav. I'm a child and adolescent psychiatry fellow in Baltimore, and I am here on behalf of the Joint Legislative Action Committee, the Maryland Psychiatric Society, and the Washington Psychiatric Society. Now, we have submitted our support in writing to the committee So I'm here to use my time to tell you one story. The patient information is completely de-identified. So I'm talking about a family who lives in the southern tip of St. Mary's County. It is a 3-year-old and a 5-year-old, both very anxious, very hyperactive, and unable to engage in school and unable to sleep away from their mom, who is disabled and is a homemaker. The father works 2 jobs, both minimum wage. So they tried to access services in their county, and everything or everyone that is on the state medical assistance program and is a child psychiatrist lives at least or works at least 2 hours away from where they live. And the child is not able to tolerate being in the car for 2 hours. So this was the situation for 6 months. And then finally, they were able to access telehealth services with us in Baltimore because of the pandemic. And working with this family for 3 months, we have achieved a lot of success. The child now sleeps in their own room. The parent is able to get a good night's rest. She is attending school, although online school is of course very difficult for these children. And so what we want to see is really to have this access that has happened by circumstance continue to exist beyond the time of the pandemic. They also have technology issues, and we have often relied on audio-only communication when necessary. So I would also support that part of this legislation. So thank you for giving me your time, and I'll also answer any questions that you might have.
Perfect timing, Dr. Jadhav. Thank you. So that is the proponents panel. So we'll take questions now, and then after that, we will see the favorable with amendments panel. The first question is Delegate Cullison.
Thank you very much, Madam Chair. Thank you all for presenting the bill. I believe this question is for Dr. Jones. You spoke to mental health, substance abuse, but the bill seems to refer to all health areas. I'm wondering if you intended for the bill to be limited to behavioral and mental and social and working on substance abuse issues, or if this was a generic telehealth bill requiring payment parity across all kinds of visits.
So my statement was framed around substance abuse and mental health because that is the area that I represent. However, I certainly don't have any reason to have a difference in feeling about access to telehealth or telehealth expansion for general medical care services.
Thank you, Madam Chair.
Absolutely. Delegate Lewis-Young.
Thank you, Madam Chair. Thank you for bringing this issue forward. It's an important priority to many of us. In fact, just a little over an hour ago, we had a very extensive and robust conversation on House Bill 123, a very comprehensive telehealth bill that has been negotiated with all of the stakeholders. In fact, it's so comprehensive that I withdrew my own bill. So I'm curious if you all are familiar with that bill, and if you feel that there's something in your legislation that isn't covered by that particular piece of legislation.
Yes, Delegate, if it's okay, I can answer that question. Great, so we want to thank Delegate Pena-Melnick for introducing that bill. We think there's a lot of good things and we support expanding to audio-only services. I think where our bill critically differs is that this covers healthcare practitioners who are licensed, registered, or otherwise authorized to perform telehealth services in Maryland. And that difference allows for, and will become more clear when we introduce House Bill 732, which allows for out-of-state licensees to provide telehealth services that aren't participating in the compact. So we thought that language or otherwise permitted by law to perform telehealth services was very important to make sure that we would capture situations like that.
Thank you for that clarification.
Thank you.
Next question is from Delegate Krebs.
Sorry about that. Thank you. And I was just on that very intensive work session that we had on House Bill 123. We're making some great strides, but I was looking at the fiscal impact, and right now currently, and I'm assuming that right now we're doing this with Medicaid, and the governor's got it in the budget I assume it's in the budget on an ongoing basis, and it has the numbers in here, 8 million going up to 16 million. And it says right here, in this bill, it removes the language that requires Medicaid to provide telehealth services subject to the limitation of the state budget. So do you know, I want to make sure that the other bill has this same language in it that would take out these limitations in the state budget. Do you know if both bills have the same language and that's what the end result would be?
I'd have to double check on Delegate Pena-Melnick's bill in terms of how the state budget's appropriating for these services. But I've talked to our budget team and the folks in the administration, and we're prepared to budget for this legislation to make sure that we can afford these services.
Good, that's great, thank you.
Yep.
Next question is from Delegate Hill.
Thank you, Madam Chairman. I just want to follow up on Delegate Lewis Young's question. Is there any reason why you all didn't simply offer an amendment to Delegate Pena-Melnick's bill, since you listed only one thing that you think your bill is doing that isn't already covered? Is that a possibility that we just amend her bill with that you could give us an amendment that would address your issue?
Sure, I'd have to review that with our team, but I think the idea was we wanted to make sure we captured this, and we were uncertain about where it was going to shake out with the different stakeholder groups that are working on this bill. And we wanted to make sure by introducing our bill that specific language was there to open access to out-of-state licensees and make sure that's there. But nonetheless, we do applaud the group for working together the last couple of weeks to make sure that in some form we are able to provide audio-only services.
Thank you.
Thank you.
Chairman Pendergrass.
Thank you, Madam Chair. I was looking at the amendments from the MHCC. I don't believe you addressed any of them in your testimony. Did you have any comments about the amendments that were submitted? Have you worked with them?
So I've spoken to Ben Steffen and the MHCC team about their amendments. And while we do think it's important to study these matters, we don't necessarily support the sunset. We understand that this process is one of compromise, and we're willing to work with the stakeholders, but nonetheless, we would like this to move forward on a permanent basis. And if studying is important, I think it would be important to kind of study and get a better idea of how these services affect the healthcare community at large.
Thank you.
Thank you.
Madam Chair.
Delegate Bandari.
Yeah, thank you, Madam Chair. And these telehealth bill are wonderful. I will support, and there are so many. We have to put it together, absolutely. But I'm curious if there is any investment requirement to improve quality, technology, and infrastructure and remote patient monitoring system when we are talking about payment parity in the medical program with telehealth.
Could I ask a clarifying question, Delegate Bandari?
Yeah, my question is, I'm curious when we are talking about payment parity in the Medicaid program and so many programs using telehealth services, I'm curious to know if there is any investment requirement you think should be needed moving forward to improve the quality, like these providers should invest in technology as well, in infrastructure and remote patient monitoring moving forward. What do you think these careers they think about this, like improving the technology?
Sure, I think there is room to evaluate that, and I think the audio-only portion of this bill kind of speaks to the fact that that infrastructure isn't there. But I'd be happy to follow up with our Medicaid team to get any more information on kind of the investments or the strides they're making towards those efforts.
Thank you.
Thank you.
Wonderful. And seeing no more questions for this panel, we'll move on to the favorable with amendments panel. We can hear from the Healthcare Commission. We have Ben Steffen and David Sharp. I think Ben Steffen is here.
I am here. Delegate Kelly, members of the committee, Chairman Pendergrass. The Healthcare Commission is here to, first of all, point out that our efforts to promote telehealth did not begin with the pandemic, but began more than a decade ago when the pandemic struck. We swung into actions with outreach efforts to engage small providers, working with the public through sweat equity. We engaged giant and radio stations in the state to broadcast public health announcements regarding the benefits of public health. So I think our messages are pretty clear. We support telehealth, but we believe and we should move forward prudently. There are questions about the quality, the effectiveness, and the cost of telehealth that need to be examined more carefully to meet those objectives. We have proposed two things that I think are really important, and a study that would then lead to long-term conclusions on the benefits of this new modality, as well as an opportunity for the legislature to pause and consider whether it wants to move forward with telehealth services on a permanent basis and remove the sunset provisions in the law. I want to emphasize, and I listened carefully to Dr. Jones' statements, very convincing, and certainly in terms of behavioral health is one of the services which benefited more than anything else from telehealth over the pandemic. But we should not, across the board, simply adopt parity rules until we have a better understanding on the benefits, the safety, and the cost comparativeness of this important methodology. Thank you, and I ask for a passage with amendments offered by MHCC.
Thank you. David Sharp.
So good afternoon, Madam Chair, Chairman Pendergrass. I'm here in support of the testimony provided by our Executive Director, Mr. Ben Steffen, and available to answer any questions that the committee may have.
Wonderful. Let's hear from Matt Celentano and then Lori Doyle, and then we'll open up to questions. Matt?
Thank you, Madam Chair, members of the HGO Committee. I'm Matt Celentano here today on behalf of the League of Life and Health Insurers and America's Health Insurance Plans, or AHIP, favorable with amendment on House Bill 731. We have been at the table for months and months discussing telehealth, and will continue to be so, to try to figure out the best way forward with appropriate telehealth policies this year. We just want to make sure that everyone on this committee knows that if the Maryland General Assembly were to take zero action this session, telehealth does not go away. It has been in existence since 2012, and it will continue to do so. That being said, we will continue to be at the table to figure out what is the best way forward this year to improve our telehealth policies, and we thank you for the time. Thank you.
Thank you. Lori Doyle.
Thank you, Madam Chair. Lori Doyle, on behalf of the Community Behavioral Health Association of Maryland, also support with amendments. Clearly, there are two very different populations served by this bill: commercial insurance populations and Medicaid, significantly different. Medicaid population tends to be poorer, so less access to video technology, and also sicker, requiring more frequent supports, also by peers and paraprofessionals. And so when you look at the audio-only language, we ask that you take a look at what's in House Bill 551, which I believe you'll be hearing this afternoon. We think that's a more comprehensive approach to audio-only services in the Medicaid population. The other area that we hope to beef up, and I think Delegate Bandari was emphasizing this, is the use of remote patient monitoring. We were in a workforce crisis before the pandemic. We'll be in a worse one after the pandemic. And remote patient monitoring is really a game changer. It allows us to extend our workforce. Right now, Maryland takes a very narrow approach to remote patient monitoring. It covers only 3 diagnostic conditions, even though the target population is the at-risk chronically ill population, like people with schizophrenia and other behavioral health disorders. They are not allowed to use remote patient monitoring. And we in the community have been using some really remarkable technology for a number of years now that allows us to use our scarce human resources in a targeted way to those who are most at risk of ED and hospital utilization. So we ask that you take a look at those 2 areas, and we appreciate your time and ask for your support of the bill. Thank you.
Thank you very much. First question comes from Chairman Pendergrass.
Thank you, Madam Chairman. This is either for David or Ben. How many meetings did you have over the interim, and how many stakeholders were represented in those meetings?
David, why don't you answer?
Sure. Thank you for the question, Chairman. Pendergrass. So we convened a work group that had roughly 70 different stakeholders. And then we had 5 formal meetings and a number of one-off or small group discussions throughout the fall.
Thank you. Thank you, Madam Chair.
Absolutely. I don't see any further questions for this panel. Last call. Wonderful. Thank you so much. And that concludes the hearing on House Bill 731. We can move right into House Bill 732, Healthcare Practitioners, Telehealth, Out-of-State Healthcare Practitioners. Jake, do you want to start on this one as well?
Yep. Thank you, Delegate Kelly, Madam Chair, Madam Vice Chair, members of the committee. For the record, I'm Jake Whitaker with the Governor's Legislative Office. This bill is also part of the Governor and Lieutenant Governor's commitment to addressing the opioid epidemic by increasing the number of healthcare providers available to Maryland patients. House Bill 732 allows state practitioners or out-of-state practitioners to provide healthcare services to Marylanders via telehealth. Prior to the pandemic, the lack of available healthcare practitioners presented a barrier to accessing quality healthcare. The COVID-19 pandemic has only increased demand for these mental health and substance use disorder services. To be clear, this bill is not aimed at interfering or undermining any of the Health Occupation Board's interstate compacts. We simply want to create a pathway forward for providers in states that are not participating in one of our compacts. We applaud the boards for the hard work they've already done for establishing some of these interstate compacts. In fact, one of our administration bills this year is an interstate compact for the Board of Professional Counselors. Maryland can be a leader in maximizing the number of licensees available to their patients, and we hope the committee will support it by voting a favorable report. And one thing I also want to point out as well is that we'd be happy to meet with any of the stakeholders to make sure that we address any of their concerns, to make sure that we have as many licensees as possible available for Marylanders. Thank you, and if okay with you, I'd like to turn it over to Dr. Jones.
Absolutely.
Thank you, Jake.
Thank you.
In 2019, the Behavioral Health Administration performed a statewide workforce survey of behavioral health administrators and clinical staff. The majority of those that responded to this survey, 60 to 80%, reported that they felt that there were either somewhat adequate to not at all adequate staff for all types of staff persons asked about in the survey, which included staffing for psychiatrists, psychologists, therapists, general medical physicians, and other staff types. In March 2017, the National Council of Behavioral Health released a report compiled by a 27-member panel of experts drawn from providers, payers, government agencies, and psychiatric associations. The report indicated that there is a national shortage of psychiatrists, with 77% of the United States counties reporting a severe psychiatrist shortage. According to the NCBH report, the pool of psychiatrists working with the public sector and insured populations declined by 10% from 2003 to 2013. There has been no great influx of psychiatrists since that time, and as Lori already mentioned, we're expecting there to be a greater contraction of the workforce after COVID. Among many other recommendations, they note that we can improve the efficiency of the delivery of psychiatric services by expanding telepsychiatry and by reducing regulatory barriers. This bill would, in effect, provide for expansion of services by improving patient access to healthcare practitioners in communities experiencing a healthcare practitioner shortage. The passage would lead to the possibility for more ready access to care, more time to deliver care to vulnerable populations with complex behavioral health needs, more time to collaborate with other care providers on coordination of care, improved ability to refer complicated patients to specialty care, increased desire to recognize and diagnose behavioral health conditions in non-behavioral health settings, which is one of the many questions that providers pose when you ask them why they aren't screening for behavioral health conditions. The biggest concern that they have is that there's no one to refer someone to if they screen someone who's positive, and there's no treatment. This would remove that or decrease that as a barrier to diagnosing behavioral health conditions in the general population. Passage of this legislation would make it easier for consumers of specialty behavioral health services to access providers and treatments not available in the state of Maryland. like access to the Amen clinics in Northern Virginia. The Amen clinic model uses non-traditional methods. They use brain spectroscopy imaging, which measures blood flow and activity in the brain to diagnose and treat behavioral health conditions. Passage of this legislation would allow for a consumer to go to their local hospital's nuclear medicine department for a brain scan and then have treatment with a provider at Amen from the comfort of their home, rather than having to drive to Northern Virginia for this care, which may not be possible. Or you can get treatment for severe borderline personality disorder with experts of dialectical behavioral therapy in Washington State. For the aforementioned reasons, we respectfully request a favorable report on House Bill 732, and we would be happy to answer any questions.
Thank you, Dr. Jones. Let's hear from Samantha Ruckert. Is Samantha here?
She should be in the room.
I'm right here.
Wonderful.
Okay. Good afternoon, Madam Chair and members of the committee. My name is Samantha Ruckert. I am a psychologist on the Board of Examiners of Psychologists. I'm testifying today on behalf of the board in support of House Bill 732 with one amendment. You should have received the board's position paper. This bill authorizes out-of-state licensed psychologists to provide telehealth services to patients located in Maryland and requires the board to register out-of-state providers. This bill expands the telehealth process that the board currently has in place and establishes a more permanent telehealth program. The board agrees that expanding access to mental health services for Maryland's residents is extremely important, and the ongoing pandemic has shown how essential telehealth services can be. The board supports this bill because it increases access to services, keeps the process simple, and does not create an operational or financial burden on the board, licensees, or Maryland residents. The board's only concern is that different states have drastically different standards regarding the education and training of licensed psychologists, and not every state meets the rigorous standards that the General Assembly has determined best protect the health, safety, and welfare of Maryland residents. To avoid any confusion and eliminate the possibility of circumventing the board's licensing requirements, the board asks that the bill be amended to include the following language. On page 3 in line 9, after practitioner, insert became licensed, certified, or otherwise authorized by law to provide healthcare services in the other state under requirements substantially equal to the licensing requirements established by the appropriate health occupations board in this state. The board respectfully asks that you vote in favor of this bill, including the aforementioned proposed amendment. Thank you for the opportunity to testify. I'm happy to answer any questions you may have.
Thank you. And my apologies, I should have taken questions after the two favorable without amendment. Do we have questions for the proponents of the bill outside of the subject of the amendment just proposed? I don't see any questions. Do we have any questions on the favorable with amendment? I do not see any questions. We do have an unfavorable panel, which will be Steve Wise and Robin Elliott. Steve?
Thank you, Chairman Kelly and members of the committee. I appreciate the opportunity to be here. I'm here for MedChi, the OBGYNs, the emergency physicians, and pediatricians. First, let me thank the administration for the steps that they took when the pandemic first hit, both to make adjustments to the telehealth law, but also to provide a broader base of providers that could serve patients in the states. Those were both very helpful executive actions. And I agree with the comments that were made by the prior panel about mental health being a particular beneficiary of that and something that should continue. However, we don't think that the vehicle that is proposed by this bill, the registration process, is necessary in light of the compact that this state entered into, the Interstate Medical Licensure Compact, just a few years ago. That provides a physician with the opportunity to be licensed in their home state, but also more easily become licensed in other states. That process involves simply designating another state that you want to be licensed in, and then your home state provides information to that state. And I understand the process to be pretty efficient. In addition to that, the disciplinary actions that may take place with physician providers are much more easily communicated through the compact. This bill requires the practitioner to actually notify the state of Maryland if they've had a disciplinary action. The bill also doesn't provide for any reciprocity, which is a major feature of the compact. So we just don't think you need to set up a separate process, given that the compact was just entered into and seems to be the right process for this, this ability of practitioners to move from state to state. Happy to take any questions.
Thank you. Let's hear from Robin Elliott.
Good afternoon, Robin Elliott. I'm here today on behalf of the Maryland Nurses Association. Also, we represent the professional associations for social workers, professional counselors, occupational therapists, and a network of FQHCs. Very much appreciate all the governor and the Department of Health's actions in the past year around telehealth, and like that they have started this conversation with House Bill 732. The specifics of 732 do raise some concerns for us. You have our written testimony, but just wanted to highlight a few. Number one, it's Mr. Wise mentioned this, but it's patient safety. When we look at compacts, they have very comprehensive agreements amongst boards across the country on how to discipline out-of-state providers. As Mr. Wise says, that's not present in this bill. So we think it might actually leave some Marylanders vulnerable, and our boards simply don't have the financial or legal resources to do so. I will note that there are 3 compacts already in the state of Maryland. Nursing's one of them and the oldest. You all have 4 pieces of compact legislation in front of you just this session. And I believe there are 8 professions that are currently under the development of compacts with the state, the Council of State Governments. So that is a wonderful model, and we'd be happy to continue to work with the governor's office and the committee on this issue. Thank
Wonderful.
you.
Thank you very much. Do we have questions for this panel from the committee? I see Delegate Bandari.
Thank you, Madam Chair. As we know that in 2019, Florida has enacted legislation establishing a registration process for out-of-state healthcare professionals. I'm curious, like if this bill is enacted into law, current licenses that leave out of state may choose not to renew their licenses and instead register as an out-of-state care practitioner and provide only telehealth services to our state residents. How does that affect our economy, number one? And number two, what are the best practices of Florida? Did they, when they enacted into law, did they have certain challenges? What are the best practices? Steve or anybody could answer that.
Delegate Bandari, I appreciate the question, and I did know that Florida enacted this and has kind of been the model, but I am not familiar with the difficulties they might have had or benefits they had with implementing it. But your point about this setting up a situation where physicians may choose only to offer telehealth into the state, I think is something the committee should consider. Because as we saw during the pandemic, telehealth was an important thing, particularly to the mental health community, but we also very much needed in-person services in emergency rooms. And this bill doesn't really address that. So I hope that helps answer your question.
Thank you.
Delegate Lewis.
Thank you, Madam Chair. Thank you so to the sponsor for bringing this bill. My question is for Ms. Elliott. You mentioned that there are a number of bills with a similar kind of purpose under consideration this year. You said several other compacts. And I wonder if you could explain that a little bit better. Are you saying that there are too many compact bills, or that this is a good year for compact bills, or just help me understand your point. Thank you.
Great. Thank you, Delegate Lewis. I would say this is a great year for compact bills. As representing the nurses, they've been under a compact since 1999 and have seen it really work. There are now over 30 states in the nurses compact and maybe 10 more coming online in the next year. So you have 4 bills in front of you. I don't think you've heard all of them, but all would create a separate compact for occupational therapy, speech therapy, psychologists, and occupational therapists. And those compact bills have normally been worked on for a couple years. They're very comprehensive and represent agreement across many of the different stakeholders. And so they're a great model for the legislature to consider. And I suspect that you will see many more compact bills in 2022 and 2023.
But you're saying that, and thank you for that overview, but you're saying that this particular compact bill that we're discussing today has not been as well developed as the others that we'll see? Is that the problem that you're referring to?
Yes, so
in your objections?
So this bill isn't actually a compact model. This is not an agreement amongst states. It is Maryland recognizing out-of-state applicants in terms of a registration process. It's a very different model. Compacts represent agreements across states. This would be singularly Maryland deciding to do this. And Florida has done this. Florida is a little bit different. As we know, there are a huge number of people who go to Florida from out of state in the winter months. And so I think that may have been one of the compelling reasons that Florida looked at the model in front of you, but Maryland may be very different. And so we are urging consideration of a different model, the compact model.
Thank you very much, Madam Chair.
Delegate Cullison.
Thank you, Madam Chair. And I think I want to try to clarify just a little bit more, Robin. So under this bill, a practitioner in Washington State could literally solicit, who has gone through the process designed in the bill, as an independent agent, could literally solicit patients from Maryland independently, as compared to a physician working within the compact, who is signed on to all the agreements of the compact, and with regard to training and discipline and all the kinds of requirements, professional requirements that go with it, who would be a part of that bigger network of the compact network. Is that kind of how you would see this difference, or?
Yes, I think that's a good way to frame it. So the compact agreements are much more comprehensive. What this bill would require is what we call an unencumbered license. So you can't have a disciplinary action against you in another state. I would note that the bill requires something called a resident agent. So in order to come into Maryland, the practitioner would have to have a resident agent, which is simply an entity which can receive official correspondence. The reason this is so important is because that individual practitioner that you mentioned in Washington State, or a small group practice, is very unlikely to be able to get a resident agent or want to encounter that administrative costs. So this does allow for movement of some out-of-state practitioners, but perhaps not all, because of that one factor. This is not to advocate for eliminating the resident agent requirement. It's just to note that there's an impact of it.
Thank you, Madam Chair. Thank you, Robin.
Absolutely. I don't see any more questions for this panel. So with that, we conclude the hearing on House Bill 732. Thank you very much. And we will move on to House Bill 551, which is Delegate Bagnell, a Maryland Medical Assistance Program and Health Insurance Coverage and Reimbursement of Telehealth Services. Delegate Bagnell.
Good afternoon, Chair, Vice Chair, and members of the committee. For the record, I'm Delegate Heather Bagnall, and I am here testifying on behalf of HB 551. You have my written testimony, so I will try to summarize. I don't need to tell this committee the value or importance of telehealth or the need for network adequacy, especially in the realms of mental health and substance use disorders. So I will speak to the need for this bill specifically. Yesterday, we heard several bills which addressed the disparity with access issues for those with private insurance versus those with medical assistance, that these disparities make it harder for those who are already financially challenged trying to get equal healthcare services. This bill would allow patients to receive care in their homes and in the location of their choice with appropriate privacy protections while removing additional burdens such as transportation and childcare costs. It would allow patients to receive services via audio only to address not only the digital and tech divide, but also to acknowledge that for many Marylanders, that is their preferred delivery method. Would authorize professionals who deliver care and support services at substance use disorder and mental health program locations to deliver services via telehealth. And it creates equity in reimbursement, so we are not minimizing or devaluing any chosen delivery method for service, ensuring consumer choice. The impact of COVID-19 on Marylanders with behavioral health needs will extend long after the pandemic, and we don't want to offer services just to take them away again. This bill is needed to ensure access to services for all Marylanders, regardless of race, income, disability, location, or insurance coverage. That Marylanders will be able to choose their preferred, most comfortable, most effective delivery method for services. That providers are incentivized to invest in an array of delivery methods, and that we are meeting our commitment to ensure not only parity of services for behavioral health, but parity of reimbursement, so we are not creating an unequal playing field. With that, I will turn my time over to my panel, and I ask for your favorable report.
Thank you, Delegate Bagnall. Now, the first person I have from your panel is Kim Wireman. Is that correct? Perfect.
That is correct. Thank you. Thank you, Madam Chair.
Kim?
Yes, this is Kim. Can you hear me?
Yes, thank you. Go ahead.
Great. All right. Very good. I'm Kim Wireman, president of Powell Recovery Center and also board member of Maryland Addictions Directors Council. We're here in support of HB 551 to extend coverage for telehealth services under Maryland Medicaid. Powell has provided life-saving addictions and dual recovery treatment since 1994 in Baltimore City. All Powell clients are in the public health system with Medicaid or uninsured funding. Approximately 85% of Powell clients present seeking treatment for fentanyl dependence. With the COVID pandemic and the state of emergency in March 2020, Powell implemented telehealth treatment rapidly in order to continue to engage 280 clients in desperate need of continuing residential treatment. HIPAA-compliant technology, along with 54-inch TV sets, Chromebooks, and tablets, were supplied to each residential unit. Group treatment, individual treatment, and case management was delivered using telehealth. From April 2020 forward, virtual weekly supervision, case conferences, and trainings for counselors and clinicians all focused on delivering telehealth services. Group and individual sessions for all ASAM levels of care continued to be delivered under COMAR regulations. COMAR regulations are the same for face-to-face services and telehealth services. By this, I mean the state of Maryland sets all the regulations for who can deliver the service, the length of the service, what content can be included in the service, and the clinical documentation that needs to occur. While the state of Maryland temporarily reduced some of the weekly hours for the most intensive treatment during the state of emergency, other COMAR regulations remained in full effect. We are not advocating for the continuance of those reductions due to COVID after the end of the state of emergency. For our outpatient services, many patients don't have access to Chromebooks that can carry audiovisual services. Neither do their cell phones have the ability to provide audiovisual services. For these clients, we use audio only for patients in order to keep them engaged in critically needed treatment and critically needed case management and support so that their continuance in recovery can move forward. In order to ensure HIPAA compliance and client consent, clinicians and counselors at the beginning of each session ask for the consent of the client to have the service delivered in audiovisual or audio only, as the case may be, and they also confirm with the client that they're in a safe and confidential location. Telehealth audio-only sessions have the same clinical and billing requirements as face-to-face treatment services. Both must be pre-authorized by Medicaid. This means the client must meet ASAM clinical criteria and be pre-authorized for all services. In June 2020, the Maryland Addictions Directors Council surveyed 400 clients across the state in residential and outpatient service receiving treatment via telehealth. Over 80% expressed satisfaction with the individual and group sessions delivered by telehealth and audio-only services. The costs for telehealth versus face-to-face are essentially the same. The overwhelming cost component of care is personnel. Clinicians and counselors are engaged in services via telehealth for the same length of session as face-to-face treatment. For patients in residential care, clients must receive treatment from a licensed residential facility, not their homes, as required by COMAR. Hence, the residential setting is the same cost regardless of how the therapeutic services are delivered. Much of SUD and outpatient mental health is structured into fee-for-service billing or bundled daily rate billing. This means that there is a clear COMAR definition for the length of service, who can deliver the service, what quality standards are included, and content is included in the services. Bundled daily SUD rates tightly restrict any additional Medicaid billing. Telehealth does not change or open up new and different billing or amend COMAR, current COMAR billing requirements in any way. Providers must be licensed by the state to provide those services and must be accredited by a state-approved accrediting body for all levels of care that they provide. In closing, thank you for allowing us to testify. Powell Recovery Center and Maryland Addictions Direction Council express their support for HB 551.
Excellent job with your timing. Let's move on to Latoya Congolo.
Yes, thank you, Madam Chair, Madam Vice Chair, and committee members for allowing me to testify at this important hearing in support of HB 551. My name is Latoya Congolo, and I'm a licensed clinical social worker and licensed clinical alcohol and drug counselor. My husband and I own Work Life Behavioral Health located at 7310 Ritchie Highway, Suite 307 in Glen Burnie, Maryland. Our clientele consists of individuals ages 4 and over receiving services in person, in home, and through our teletherapy platform. Many live across the county in suburban and rural areas, and many have limited access to transportation. Approximately 66% of our clients are African American, Hispanic, and Asian. 54% of our clients are Medicaid and Medicare recipients. Approximately 31% have private insurance and 15% are self-pay. The COVID pandemic forced us to be innovative in the way we provide services to nearly 1,000 Anne Arundel County residents who trust us with their mental health and substance use counseling services. As a result of the pandemic, we transitioned to telehealth in March of 2020, both by audio and telephone. As a result of telehealth, children are receiving services without the hardship on parents having to adjust their work schedules to accommodate in-person sessions. Individuals in the criminal justice system have been able to successfully satisfy the requirements of probation and parole. Parents who are seeking to regain custody of their children have been able to comply with the requirements of DSS while balancing work and other responsibilities. We've seen an increase in consistent treatment, which has led to clients needing less therapy sessions as they progress through treatment. In conclusion, I'd like to reiterate that telehealth has decreased barriers such as transportation, missed time from work and school. There's been a reduction of missed appointments, which has allowed patients to be more consistent with treatment. Telehealth has made mental health and addiction services possible to all. And I'd like to thank you for your consideration for my testimony. Thank you.
Thank you. Very nicely done. Christina Spangler.
Hi. My name is Christina Spangler. I am with Maryland Coalition of Families, and I am a lifelong resident of Southern Maryland. I'm speaking to you today in favor of House Bill 551. I am a married mother of 4 and I work a full-time job. My oldest son is 12 years old. He struggles with bipolar disorder, nonverbal autism, epilepsy, and extreme self-injurious behaviors. Because of his challenges, myself and 2 of my other children, who are 10 and 4, have been diagnosed with post-traumatic stress disorder. My family has been living in crisis for close to 10 years. And because of the pandemic shift towards telehealth, my family has finally been able to take crucial steps towards wellness. For myself, I have never been able to access individual therapy sessions. I can't take the time off work. I can't pay $30 an hour for a special needs babysitter. I don't even make $30 an hour. The time and the travel, it's just too much stressor for me to find the maximum benefits of an individual therapy session. Now I can use my lunch break and I can attend my sessions while my children are home and I can supervise them. My oldest son, his intense needs, there are no providers in our area and we have to go to Baltimore. A 20-minute appointment takes so close to 12 hours for my family to travel up the road, fight the traffic, see the appointment, and then get back home. Now we can have those appointments while we're here with the rest of my kids. I think the biggest contributor to telehealth for him is that our providers are now inside of our home. They see our life the way that I see it. They have been able to make tremendous modifications to his treatment plan, and we have seen the most progress in 10 years just by their eyes being in our house versus us being in their sterile clinical room a few hours away from us. Telehealth appointments have relieved endless stressors for my special needs families and has allowed us to maximize the benefits of these medically necessary services.
Were you finished? Do you have another sentence? You're good. Thank you so much for your testimony. We really appreciate it. Ellen Weber.
Thank you, Madam Chair and Vice Chair and members of the committee. I'm Ellen Weber with the Legal Action Center, and we convene the Maryland Parity Coalition, which thanks Delegate Bagnall for her leadership on HB 551. As we heard today from Dr. Jones, the need for mental health and substance use disorder treatment has skyrocketed as a result of the pandemic, and that need for care will extend far beyond the public health emergency. HB 551 will ensure that the door to these life-saving services will not be closed. There are 4 points I'd like to make. First, health equity requires coverage of audio-only telehealth and payment parity for mental health and substance use services in both Medicaid and private insurance. Across the state, communities of color and persons with lower incomes have had an increased need for mental health and substance use services. Johns Hopkins data shows that Medicaid recipients have used audio-only telehealth at a much higher rate than individuals with private insurance, and that has been sustained through the public health emergency. 84% of Hopkins patients have received behavioral health care through telehealth. Without coverage and sustained funding for audio-only, care will be taken away from the most vulnerable Marylanders. Second, patients must be allowed to choose the mode of service delivery to ensure patient-centered care and healthcare quality. Patient satisfaction is increased with treatment adherence and better health outcomes. This is a decision for patients and their providers, not carriers. Third, the research literature on telehealth delivery of these services supports all the benefits that you've heard today. Improved access to care, reduced travel barriers. Individuals prefer telehealth to treat stigmatized conditions. And most important, the research data also shows that audio-only and audiovisual telehealth are effective for mental health and substance use treatment when compared to in-person care. And finally, other states in our region and across the country have adopted coverage of audio only and payment parity in Medicaid and private insurance. Maryland's carriers are already implementing these standards, and we urge you a favorable report on 551 so that they can continue to do so here. Thank you very much.
Thank you very much. Do we have questions for this panel? Giving everyone a second to get their hands up if they have any. I don't see any questions. Thank you. It means the panel oh wait, Delegate Bhandari does have a question.
Yeah, quick question. Thank you, Madam Chair. Department of Legislative Services has not provided the sufficient information about the fiscal impact of this legislation on Medicaid or state employees and retiree health and welfare plan. Is it possible, Delegate Bagnall, when we convene in our subcommittee, if you could provide that information?
Yeah, I'd be happy to circle back with Department of Legislative Services. They weren't definitive.
Thank you.
Excellent. And a question from Delegate Cullison.
Thank you, Madam Chair. Couldn't get my mouse over to the raised hand. I want to thank the panel for presenting this bill in such a compelling way. So we heard on 731 that they were looking to cover with parity the telehealth, particularly with Medicaid, but also with commercial carriers. What kinds of protections is there a difference between the protections that 551 provides for patients and 731, the earlier bill? Is there a difference between them?
I can answer that, Delegate Cullison. Thank you very much for your question. There are some critically important differences. And the first difference, and we again appreciate the administration's support for payment parity in both Medicaid and private insurance. What 551 would do is it would make explicitly clear that mental health and substance use disorder conditions, the treatment services must be covered under telehealth. And to the extent that the state Medicaid has the discretion in regulation to identify which providers are allowed to offer telehealth services and be reimbursed for those services, 551 makes explicitly clear that licensed practitioners as well as licensed treatment programs must be included in those providers who can deliver these services. A second important point is that it would also require the coverage and reimbursement for programs that currently provide services by peers and paraprofessionals in person. To the extent that those paras and professionals also deliver services via telehealth, this bill would require the Medicaid program to reimburse the program for those services. A third important point that our bill would cover is that it ensures that commercial carriers allow patients to make the choice as to the mode of service delivery for mental health and substance use disorder care. This is a decision, as I said, that belongs to the patient with their provider, and it's not one that the carrier should dictate. And so it would not permit the carriers to require the use of a telehealth service in lieu of in-person services. And then a third and another important two more distinctions. What 551 would do is it would retain the current standard under our network adequacy regulations for the counting of telehealth services for purposes of meeting network adequacy standards. And that current standard requires consumer member consent before the telehealth service can be counted for purposes of meeting network adequacy standards. We think that's essential to retain. As of right now, we know that our state is having a difficult time. The carriers are having a very difficult time meeting network adequacy standards for mental health and substance use disorder conditions. And we think that that needs to be resolved, ensuring that there's in-person service delivery. And again, allowing for telehealth services to be counted, but with patient consent. And then the last and final point I want to make is that that 551 would also require compliance with the Mental Health Parity and Addiction Equity Act for both Medicaid and Medicare. We know that there have been violations of that law for purposes of network adequacy, for purposes of reimbursement. And right now in the Medicaid statute, it actually requires prior authorization for the receipt of telehealth services for mental health and substance use disorder conditions. There is no such comparable provision with regard to somatic care. That's a parity violation. So the bill would require those problems to be resolved.
Thank you, Alan. And thank you, Chair.
And I think that answer also answered Delegate Sample Hughes's question. Is that right? You put your hand down again? Great. So I think with that, I see no further questions for this panel. Let's move on to the favorable with amendments panel. We have Matt Celentano and Allison Taylor. Matt?
Good afternoon, Madam Chair, members of the HGO Committee. Thank you for giving me some time today. My name is Matt Celentano on behalf of the League of Life and Health Insurers of Maryland and America's Health Insurance Plans, or AHIP. We are here favorable with amendment on House Bill 551. Like my earlier testimony, we just wanted to let you all know that we have been at the table for the entire duration of the telehealth discussions. We will continue to be at the table. There are some additional measures in this bill that should be discussed in the subcommittee process, depending on whatever vehicle this committee chooses to move forward with. The one thing that we do have a comment on is, and we're not sure if the network adequacy requirements are best served in this discussion or in this bill. Many of you might know that there were already draft regulations that were issued by the Maryland Insurance Administration this past fall. They went out to all stakeholders. Stakeholders had an opportunity over a month to comment. All those comments went in by the middle of December, and there have been stakeholder work groups being led by the MIA that have already began. So we think that that process should continue to play out for the revisions to the network adequacy requirements from the couple of years ago when this committee first passed the network adequacy bill. Other than that, we are favorable with amendments on this bill, and we look forward to continuing the discussion. Thank you very much.
Thank you. Let's hear from Allison Taylor, please.
Good afternoon, Madam Chair, members of the committee. For the record, my name is Allison Taylor. I'm here on behalf of Kaiser Permanente today. Telehealth has been a huge, important part of the care we've delivered since the pandemic began. And so we've been at the table for all of the meetings to discuss all sorts of issues related to telehealth, and appreciate that opportunity. I will just say me too to what Mr. Celentano has just said, and want to reinforce the point that we've been working very diligently on a range of network adequacy issues through the MIA, and that process is ongoing. And we'd recommend that for ease of administration, that might be the better forum for addressing this particular concern rather than through legislation. But happy to continue discussing with everyone and appreciate the opportunity. Thank you.
Thank you very much. Do we have any questions for this panel? I'm not seeing any hands. I'm giving everyone just a second. Wonderful. Well, thank you so much. We have one person signed up unfavorable. That's Laura Bogley. Laura?
Thank you. Good afternoon, Madam Chair and members of the committee. I appreciate your time to speak with you today. We applaud the sponsor's purpose in providing essential health care and behavioral health care to patients through telemedicine. However, this bill is written broadly to allow the Department of Health to determine the type of healthcare providers who are eligible for reimbursement. Our concern is that this bill may be used to force Maryland taxpayers to fund the remote administration of lethal drugs intended not to heal disease, but to end human life, including abortion-inducing drugs, mifepristone and misoprostol. 60% of Americans polled agree that taxpayers should not be forced to fund abortions or subsidize the abortion industry. We are strongly opposed to teleabortion and any funding for teleabortion, including through Medicaid, the Maryland Medical Assistance Program, the Maryland Children's Health Program, and the Family Planning Program. The Maryland Medical Assistance Program is the primary program used for publicly funded reimbursements to abortion providers in Maryland. In 2019 alone, the Maryland Department of Legislative Services reported that taxpayers paid more than $6 million to reimburse abortion providers through this program. This also already includes chemical abortions. We also want to underscore the health and safety risk posed to women and girls by do-it-yourself abortion pills and why they must not be administered through telehealth. Chemical abortions are 4 times more dangerous than surgical abortions and already have killed 24 women. Maryland should put patient safety before abortion politics and codify the current FDA guidelines that require the distribution of abortion pills to be in person after obstetric medical examination because of the drug's potential for serious complications, including, but not limited to, uterine hemorrhage, viral infections, pelvic inflammatory disease, loss of fertility, and death. Because of the scarcity of abortionists and the fact that 9 out of 10 OBGYNs refuse to commit abortion, the abortion industry wants your permission to sell abortion pills online and even by out-of-state providers. Removing FDA safeguards and codifying teleabortion have become top priorities for the abortion lobby. Finally, there is no constitutional right to abortion funding. For these reasons, we respectfully ask that you preserve the good purposes of this bill and all telehealth bills by excluding their application to dangerous teleabortions. Thank you for your time and consideration today.
Thank you very much. And while I give the members a few seconds to raise their hand if they have questions, we're going to go to Delegate Lewis Young, who actually has a question for the last panel, I believe.
Thank you, Madam Chair. I guess I got to practice getting my hand up quicker because I had this question previously when Matt Celentano was up. So Matt, I'm going to ask you the question I've been thinking about for the last past half hour. is there actually a requirement for carriers to reimburse for telehealth, or do carriers just simply allow for it?
Carriers are required to reimburse for telehealth. We passed the law in 2012.
Okay, thank you.
Perfect. And I don't see any more hands up for Ms. Bogley, so I don't think we have any more questions for her. Going once, going twice, I see no more hands. Thank you so much for your testimony. This concludes the hearing on House Bill 551. And with that, we're going to move to Delegate Kipke. House Bill, he's got several, but we'll start with House Bill 601. Delegate Kipke.
Thank you very much. Just give me 1 second.
Take your time. Everyone needs a stretch. We've been doing good work so far.
I have so many today. I'm trying to find. You said 601, right? This is going to be the last binder I pick up.
Isn't that always the case?
Good afternoon, Chairman and members of the Health and Government Operations Committee. This bill, House Bill 601, is a fairly simple bill, and I believe should be fairly uncontroversial. There was a Supreme Court case and ruling that provided us the ability to further expand the plans that our existing laws that relate to PBMs impact. So one of the things that I think drives some of us crazy is, we'll get a complaint from all different players within the healthcare arena. And once we drill down, we'll find out that the plan that they are in, we have no control over or regulations over. We can't impact. A very small percentage, in fact, of plans are we able to regulate. But the Supreme Court has made it clear that we can regulate PBMs, and they are not ERISA bound. So what does this mean? All the laws that we've put on the books, whether it's to allow a pharmacist to disclose to a patient that have a cheaper option if they were to pay cash, or to prevent some of the practices that we've seen where PBMs are pocketing revenue that should be going to a pharmacist, all the different things that we've done over the years, we can now expand by changing Maryland's law to allow it to impact self-insured plans. So that's what the bill does. It's a very simple bill. As you might imagine, pharmacists around the state of Maryland cheered for the Supreme Court when they did this ruling. I also have an Attorney General's opinion that says that we can very easily do this. And the Office of the Attorney General has submitted a friendly amendment that just provides, I think, some clarifying language that hits the mark. So with that, I will conclude and ask for your favorable consideration. Thank you.
Thank you, Delegate Kipke. And we have a panel of supporters of this bill. Steve Weiner. Is Stephen here?
Yes, he should be in the room.
We'll give him a second.
I am sorry. Okay, can you?
No, it's okay. We've been moving quickly. Now it's a good time for you to go ahead.
Okay, and there's not a picture of a cat. I'm coming through.
We're disappointed, but no, you do not look like a cat. You look like your regular self.
Madam Chairwoman, Vice Chair, members of the committee, my name is Steve Weiner. I own 2 pharmacies in Baltimore City. I'm representing Epic Pharmacy in my testimony, and I thank you for hearing me today. I would urge the committee support House Bill 601 with the Attorney General's amendments. How many times has this body been told that your legislation related to pharmacy matters really affects so few people, almost that you've been told it's inconsequential. And if you're passing legislation and you're doing it because you believe in the legislation, I can't imagine you wouldn't want your legislation to be effective, and that's what this bill does. To my knowledge, there's no financial impact to the state by supporting this bill, and I would urge a favorable opinion of Senate Bill or House Bill 601. Thank you.
Thank you very much. Let's hear from James Doyle. James Doyle, are you available to testify? If not, we can move on and see if you can come back right after. Gerard?
He should be in the room, but he needs to unmute himself.
James, if you want to unmute yourself, we'll be able to hear your testimony. I don't see James. I do see Mr. Herpel, so let's move on to him while we see if we can track down James.
Good afternoon, Chairwoman Pendergrass and members of the committee. I'm Gerard Herpel, Deep Creek Pharmacy in Garrett County and a board member of Epic Pharmacies. I'm here to reiterate what Steve just spoke of and also to support Delegate Kipke on, this is a simple bill. We've heard for years how, only 25% of the insured in the state of Maryland would be affected by all the bills that we've tried to pass or have passed. And, the Supreme Court has gave their ruling and not much else to say. Thank you very much.
Thank you very much. I'm going to give Mr. Doyle one more chance.
Yes.
You're here. Wonderful. Let's hear your testimony.
Yes, I always have a little technical problems with this stuff.
It
Jim Doyle, I'm an attorney from Baltimore on behalf of the Independent Pharmacies of Maryland. And of course, these are the neighborhood community pharmacies that are generally owned and operated by local people in the state of Maryland. And they strongly support House Bill 601. The background of it is simply this, and Delegate Kipke stated it correctly. In December, the Supreme Court decided a case called Rutledge. It decided it unanimously by a majority opinion of the court written by Justice Sotomayor. It greatly expanded the role of the states and the authority of the states to regulate PBMs, even in cases involving ERISA plans. And it did that throughout the country. The problem in Maryland is that authority granted under Rutledge will not take place in Maryland unless a statutory change is made to the definition of a purchaser under the state code. And that's what has to be done. And that's what this bill does. So if you want to have a ability to regulate PBMs under the authority that the Supreme Court now has unanimously granted to the states, there must be a change in the statutory language of purchaser, which right now simply eliminates and prohibits any regulation of ERISA plans. So this would make that change in the law and bring the Maryland law into compliance with the decision of the Supreme Court in Rutledge. I think it's a very easy decision to make. And I can understand why PBM, in this particular case, PBMs, of course, oppose the law that went before the Supreme Court. And that law, interestingly, simply said that pharmacies would be entitled to recover the cost that they paid for the drug that was the prescription. And that PBMs had to make sure that pharmacies at least recover their cost of the drug. And the PBMs oppose that law.
We're timing all the testimony, so your 2 minutes is up, but we'll see if someone has a question and maybe you'll be able to expand on that. Do we have any questions for this panel? I'm going to give people a few seconds because I know it takes a little while to get your hand raised. I see Delegate Kipke has a question.
Since you were egging me on, I would just ask Mr. Doyle if he'd like to expand upon the legal the legal case that ended up going before the Supreme Court.
Yes, I would, because it was an interesting case. And as I started to say, all the state law did was say that PBMs had to at least reimburse the pharmacy for the cost that the pharmacy had paid for the drug. And the PBMs opposed that law and said it was preempted by ERISA. And the Supreme Court came back unanimously and said that that was not true. And they announced a much broader test that states would be able to use in terms of regulating PBMs even under ERISA plans. And so that was the holding of the, without getting into the actual details of the holding, but that was the bottom line holding. And that law can be implemented now in any state except Maryland, where it cannot be implemented unless this law is changed, unless the definition of a purchaser under the statute is changed. Then the Rutledge decision will have no impact in the state of Maryland, and the hands of the legislature will still be completely tied with respect to regulating PBMs under ERISA plans.
Thank you. Does that answer your question, Delegate Kipke? Excellent. We have a question from Delegate Krebs.
Thank you, Madam Chair. Part of my question was answered, but so if this bill would pass and would this level the playing field to make sure that our independent pharmacies would not have to pay below cost for prescriptions?
It would give the state the authority to implement that kind of legislation. It would still be a matter of the state exercising its judgment over whether those kinds of reimbursement policies were going to apply. But as the law stands right now, there are a lot of impediments to the state even doing that because of the way the law is written. Rutledge would allow the state to do that. Rutledge would specifically allow the state of Maryland to do that. But that would not be able to be done in Maryland unless this law is implemented and the statutory definition of purchaser, which excludes ERISA plans, unless that definition is changed.
Okay, that's great. Thank you.
I don't see any more questions for this panel, so thank you so much for your testimony. We do have 6 people signed up. 1, 2, 3, 5 people, sorry, signed up in opposition. So we'll hear first from Matt Celentano.
Madam Chair, do you mind if I defer to my friends at PCMA for them to take the lead on this one?
Absolutely.
Thank you.
So do we want to hear from Mike Johansson or Heather Cascone?
Heather, please.
Heather, please. Heather.
Good afternoon, Madam Chair, members of the committee. Thank you very much for the time. My name is Heather Cascone, and I represent the PBM industry through its trade, the Pharmaceutical Care Management Association. House Bill 601 seeks to redefine the term purchaser in statute in what's seemingly a response to the recent decision of the Supreme Court in PCMA versus Rutledge. It is our concern, though, that this bill attempts to expand the removal of the self-insured ERISA plan exemption currently in the definition of purchaser and appearing at various places in the statutes governing PBMs, thus broadening it beyond the court's finding. It's really important that we understand what the Rutledge decision does and doesn't do here in the context of this bill. Back in December 2020, the US Supreme Court issued a narrow decision on Rutledge. The court was asked to examine whether an Arkansas law regarding maximum allowable cost, or MAC, reimbursements to pharmacies was preempted by federal ERISA statute, or put simply, whether ERISA plans were exempt from the state's MAC law. Ultimately, The court held that the Arkansas law is not preempted by ERISA because the MAC law in question was simply a quote rate regulation, which is something that states have the authority to regulate. This idea that a cost or rate regulation not being preempted has been around since the mid-90s. It's not new. What's new from the Rutledge decision is that the court now considers MAC, or maximum allowable cost laws, a type of rate regulation. That said, not all PBM laws are rate regulations. Some PBM laws have to do with the operations of the plan, benefit design, or drug delivery issues. The court did not say that states can regulate PBMs with respect to every aspect of their ERISA business, that many are still preempted. We have no opposition to this or any other state applying the Rutledge decision as it appears to ERISA and MAC, but as drafted, 601 appears to go beyond the court's interpretation. Thank you for your time, and I'm happy to answer any questions.
Thank you. And Mr. Johansson, did you have something to add?
Yeah, I'll be offering some different comments. I'm Mike Johansson on behalf of PCMA. The bill appears to be a rather straightforward bill, but as most legislation in the healthcare space, it may not be. We're anxious to see the sponsors' AG advice. I'll direct you to page 2 of the fiscal note, where it includes comments from the Maryland Insurance Administration that indicates while changing the definition of purchaser, it does not expressly expand the definition to include such ERISA plans. Thus, it does not apply Title 15, Subtitle 16 of the insurance article to PBMs that solely contract with self-funded ERISA plans. Further, as Ms. Cascone mentioned, the Supreme Court decision made a ruling that PBMs can be regulated for rate regulation. A prior Supreme Court decision, which was not overturned, said that PBMs cannot be regulated on ERISA plans related to benefits or plan operations. If you look at Subtitle 16, there's more than a dozen specific statutory provisions that apply to PBMs. And by changing this definition very simply in one part of the subtitle, which provisions does the General Assembly intend will apply to ERISA-based plans and their PBMs? There's no further discussion of it. There's nothing in the fiscal note that identifies to ERISA plan holders what provisions may or may not apply to them. And based on this comment in the fiscal note that's attributable to MIA, this bill would create much more confusion than it seeks to solve. In our view, it would be best that the committee look at each of the individual provisions in Subtitle 16 and make a determination with appropriate notice to the plans and the impacts and the fiscal notes on which ones they think should and shouldn't apply. So we oppose the bill. Thank you.
Thank you. Let's hear from Kimberly Robinson.
Good afternoon, Madam Chair and members of the Health and Government Operations Committee. I'm Kimberly Robinson, Regional Director for Government Affairs for Cigna. I'm here today alongside PCMA, which I'm a member, in opposition to House Bill 601 as introduced. As Ms. Cascone said, we have no objection to states taking the opportunity to implement the Rutledge decision as it was rendered. We do believe that House Bill 601, however, is broader than that decision in making the change that applies throughout Subtitle 16 of Title 15 of the insurance article. Delegate Kipke referenced a clarifying amendment from the Attorney General's office, and perhaps that amendment addresses the concern of the breadth of the change that is proposed by House Bill 601. And so I'd be happy to, when that amendment is available more publicly, to take a look and see, because it may in fact resolve our concern. But looking, for instance, at some of the other bills you'll hear today, there is an attempt in several of those bills to place provisions that speak specifically to benefit design in Subtitle 16. And that, as Mr. Johansson just mentioned, is in direct conflict with the holding in the Rutledge case that spoke specifically to rate regulation and acknowledged that states did not have the ability to regulate the benefits under an ERISA plan. And so as things get added into Subtitle 16 that speak to benefits, as opposed to in the rest of the insurance article where benefit design for commercial plans under the state's regulatory authority typically exists. It does create that kind of a conflict, and changing this definition would exacerbate that issue. So we're happy to be part of the conversation with the sponsor and the committee about how to tailor a change to what the Supreme Court has permitted, and look forward to being part of that conversation. At this moment, we are opposed because of the breadth of the bill, but certainly believe that there is a more narrow version that would make the bill more viable. So thank you for the opportunity.
Thank you very much for your testimony. Let's circle back to Matt Celentano.
Thank you, Madam Chair and members of the committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers and AHIP, America's Health Insurance Plans, unfavorable as written on House Bill 601. I'm generally supportive of the comments of my friends from PCMA and Cigna, but just want to point out a couple of things from the carrier's perspective, and that's that we believe that the bill is broader than the PBM statute, and wading into ERISA waters on healthcare design or healthcare plan design is difficult for League members and AHIP members. We ask the committee to be cautious. This is uncharted territory for state interaction with self-insured plans. And we're not even sure that those businesses that participate in self-insured plans know how to analyze the potential impact of this bill and other approaches to the Rutledge decision. And if the committee chooses to move forward, we suggest that you tailor it more narrowly, and we'd be happy to be at the table for those discussions. But as written, we are unfavorable on 601. Thank you very much.
Thank you very much. And as committee members raise their hands, I do have a question from Delegate Cullison.
Thank you, Madam Chair. I'm not going to pick who can answer this because I think any of them can. You all alluded to the potential impact to existing ERISA plans. Can you give us an example of or two of what the potential, if as written, and doesn't single out the rate regulation piece, what potential negative impacts could happen to ERISA plans if this were changed, if any?
Sure, I'm happy to take that one. As someone mentioned it earlier, one of my colleagues mentioned it earlier, that the term purchaser that is being amended here is referenced in various other places in the code. In fact, some of the bills that this committee will hear later on today reference this definition. For example, a proposed explanation of benefits, prohibited practices for PBMs, reporting or reimbursement requirements. There are specific things that the court allowed to be clarified as rate regulation as it applied to the Arkansas law, which was very specific to maximum allowable cost. But if we take that interpretation and put that requirement on other aspects of plan administration, like benefit design or channel issue, prescription drug channel issues, it really goes far beyond what the court intended when they defined regulation. Rate regulation is not something that's new. It's always been in the state's purview to oversee. What's new about this decision is that the court is now saying MAC laws fall into the definition of rate regulation, but not other things. The court did not say that all other aspects of PBM business the ERISA exemption should be removed. In fact, the court didn't even say necessarily that this was good policy, but they did find that it would fall into the term of cost or rate regulation.
Okay. Thank you, Madam Chair.
Absolutely. We have a question from Delegate Kipke.
Oh, I think you're on mute.
This one is for Heather. Couldn't that be easily remedied by saying as allowed and determined by the Maryland Insurance Administration? So it seems like this is a rather easy fix if there was just a simple line that says that the Maryland Insurance Administration has the ability to regulate, but limiting it in a manner that is applicable with the ruling.
If I'm understanding your question correctly, yes, I believe that this would be within the purview of the MIA to clarify that the state's existing MAC statute from several years ago, and then the follow-on law that deals with appeals and remedies on appeals from the last 2 years should now reflect the court's decision. They could specify that. The bill, however, it's drafted, applies to much broader PBM regulation beyond what MAC or rate regulation would constitute.
Right. Okay. Thank you.
Wonderful. And seeing no further questions, that concludes the hearing on House Bill 601. Before we move on to House Bill 602, I just want to notify the committee we'll take a break after this bill hearing and then return for the final 4 bill hearings of the day. So House Bill 602 wins the award for longest bill title. Delegate Kipke, Maryland Medical Assistance Program and Managed Care Organizations that use pharmacy benefits managers reimbursement requirements. Delegate Kipke.
Thank you. Longest bill title and perhaps the largest fiscal note. What this bill simply does is it requires that the state spend on medical assistance and MCO organizations, that when they reimburse a pharmacy for their professional services, they do it to the amount that the state has determined helps them recover their cost, plus a reasonable professional fee. So from time to time, the state does a survey and does a study using national costs for pharmaceutical treatment, plus the cost of the overhead, and they determine what a reasonable reimbursement is. Unfortunately, as I think you'll hear from and have heard over the years, pharmacists, especially those that operate in areas of high poverty, where there's a lot of folks on medical assistance, and not enough private pay patients, they have a very hard time not going into the red. They have a very hard time staying open. I know you've heard it because these folks are extremely concerned. Many of them, even since last year, have closed their businesses. And that, unfortunately, despite all of our best efforts, continues to happen. The state, and I've shared with with some of the proponents that, in order for this to change, it's not, I don't think we really have the authority to do it in our committee. It requires the decision of leadership. And I know everybody on this committee really wants to help these folks. So I encourage them also to reach out to the leadership and to the governor's office as well, because this is a very expensive proposal. But the bottom line is it's in the best interest for all of us, for public health, to have an adequate network, a robust network of pharmacists in our community doing the good work that they do, and especially in areas of high poverty where you don't see some of these retail chains. So with that, I'll conclude and ask for your thoughtful consideration. Thank you, Madam Chairman.
Thank you, Delegate Kipke. In support of this bill, we have Tom Wieland. Is Tom here?
Yes, he should be in the room.
Let's give him a second to unmute.
All right. Hi, my name is Tom Whelan, and I own and operate Ritchie Pharmacy, a small independent pharmacy in Brooklyn Park. And I am in favor of HB 602. I'm at work today, and I apologize for the noise in the background. I do have a pharmacist covering for me up front. I'm going to just give you some numbers to give you some idea of what goes on here. Last year, my total sales in my pharmacy was 2.4 million. My net profit was 49,000, or 2.1% of my total sales. I paid $64,000 in DIR fees, or 2.6% of my total sales. Now, I know what I do to get my $64,000 in the pharmacy, but I'm not sure what the PBMs are doing to get more than I get working in my pharmacy. Not only did they get $64,000, but in addition to that, they also have common ownership of commonly owned managed care organizations. So they can steer customers to their pharmacies to make more purchases. They also get money from pharmaceutical companies that pay them to have their drugs listed on their formularies. They charge the MCOs one price for the drugs and reimburse companies, the pharmacies, at a lower price and keep the difference, which we all know is called spread pricing, which according to a study done by the State of Maryland Audit a couple years ago was $72 million. They also get what's called clawbacks by keeping a portion of the patient's copay. The Wall Street Journal says that PBM's profit is 85%, which is well above any others in the drug supply chain, and obviously me and the other pharmacists like me who do all the work. While on the average pharmacies are paid 50 cents, I sometimes get 0 cents and paid often below cost. I think this is utter lunacy, and the conflict of interest and antitrust issues, as well as simple ethical issues for healthcare, are so obvious to me and others as it should be that it boggles the mind. And thank you for my time.
Thank you, Mr. Wheeland. Let's hear from Steve Weiner.
Hello, my name is Steve Weiner. I'm representing Epic Pharmacies with my testimony. Thank you, Madam Chairwoman, Vice Chair, and members of the committee. Let's see. Tough fiscal note on this bill. So let's do a little bit of history on this bill. 3-4 years ago, I forget when, we asked to say, hey, pay us a fair rate. MCO Health Choice pay us a rate, and we'll get that rate not out of thin air. We'll take the rate that the Maryland Department of Health said it costs to fill a prescription without really any profit. They gave a cost formula. They determined what it cost us to fill a prescription, and they determined the cost. That bill was denied or tabled or studied. It became a study because it had a high fiscal note. And we responded, if you go after the spread pricing, it'll cover the fiscal note, and you'll be able to pay us a fair amount that the Department of Health determined. Did a study. Department of Health hired Myers and Stauffer, who they have a very close relationship with. Lo and behold, Myers and Stauffer said there is spread pricing in the MCO program. And I forget the numbers, but it was in like within $10,000 of the fiscal note. So we found the money. We told you where the money is. And lo and behold, we're still getting reimbursed under cost. We've been told they're going to stop spread pricing in the MCO marketplace. I hope they are. I have no idea. We've heard no follow-up. So it's expensive to pay us, look, when it doesn't pass, at the very least, thank the pharmacists in Maryland for subsidizing $90 million to the state of Maryland. If nothing else, we deserve a thank you.
Thank you, Mr. Weiner. Let's hear from Jim Doyle. Jim Doyle. Jim, are you around? I see you working to unmute, so we will patiently wait.
Jim Doyle here on behalf of the Independent Pharmacies of Maryland. We all know that the independent pharmacies are not being paid in Medicaid for the cost of their drug, and they're not being paid anywhere near the adequate dispensing fee. 50 cents is what they're being paid according to Myers and Stauffer report, whereas the actual dispensing fee is $10.49 according to CMS. But I think the big problem, and some people have mentioned it, the profit, the fiscal note rather, the fiscal note, which is a large note. The problem with the fiscal note is this: it doesn't reflect the reality of what's occurring here. This is a situation where pharmacies are actually subsidizing and reimbursing PBMs. PBMs are making tremendous amounts of money. PBMs are making tremendous profits. And I had put in my written testimony a reference to the Wall Street Journal article from a couple years ago, and the what's called the EBITDA rate, which is the rate that an industry's revenue is converted into operating profit for PBMs, is an astounding 85%. There's almost no industry that exists that gets that kind of a rate regarding EBITDA reimbursement. Profits are going into the pockets of PBMs, and this is where we need. And the fiscal note takes no account of that. It takes no account of the spread pricing. It takes no account of the rebates that PBMs are getting from pharmaceuticals for getting money on their formularies. That's what has to be addressed in this. And if that is addressed by the legislature, pharmacies will be able to be reimbursed what they should be reimbursed for their cost of business.
Thank you very much. We have three more people to hear from, Shireen Joseph, then Jared Herpel, and then Deepak Kinney. So let's hear from Shireen first.
Madam Chair and the members of the committee, my name is Sharon Joseph. I have a small pharmacy in Baltimore, and I also represent the Independent Pharmacies of Maryland. First off, I would like to thank this committee for your past support, which is actually giving us the courage to come back and tell our stories again. As I testify in favor of HB 602, I just want to let this committee know that nothing has changed for the independent pharmacies since last year. A lot of our friends have gone out of business. Some of us have taken second loans on our houses. We have maxed out on our credit cards to pay our wholesalers so we can keep serving our communities, hoping that something might come, change for the better tomorrow. And too many pharmacies are really operating on their last nickel. We are the ones who actually make a direct impact in our communities with free delivery services, which is also a check on our elderly and vulnerable customers. And we bring the communities together by participating in numerous of the small community activities too. And as we fill prescriptions, we are not just putting medications in a bottle and just slapping a label on it. We are checking for drug interactions. We are counseling our customers on the proper use of it. We are telling them pointers on what to look for if there's an adverse reaction. But with horrible payments that we are receiving from the PBMs that is forced upon us by a take it or leave it contract, we are bleeding to death. How is it fair that a PBM who does not buy a drug, stock a drug, label a drug, or cancel on the medication gets to keep all the money that is being paid on our behalf by the plan sponsors, while we who spend all this time and energy running our business does not get to keep it. They're keeping the money that plan sponsors are paying on our behalf for our knowledge and expertise. It is really totally unfair. All we are asking for is what is rightfully ours. We don't want the millions of dollars that the PBM CEOs are making. Just give us what is rightfully ours, which is the cost of the drug and the dispensing fee. Thank you for the time.
Thank you very much. I actually made a mistake, and Mr. Herpel's on the next bill, but we do have to hear from Deepak Kinney.
Thank you, Madam Chair. My name is Deepak Kinney, and I represent Hillcrest Pharmacy in Frederick, Maryland. I'm in favor of this bill as it's necessary for the survival of independent pharmacies. And again, like Shireen said, I thank all of you for your past support. And I want to bring a different perspective, 2 points that PCMA and all the people who oppose this bill will be talking about. The first one is that there have been more independent pharmacies in Maryland in the past 3 years, 5 years, or whatever it is. What I can tell you is that people who are working for chain stores are getting frustrated working 12-hour shifts, understaffed, and not being able to serve their customers. So because of the market overflow of pharmacists in the market, these frustrated pharmacists are opening new stores. When they come in, they realize that they are not getting paid, they take on debt, and there is no way for them to get out of the debt but to continue their business. So that's a fallacy that you please should ignore from the PCMA, that there are new pharmacies opening. That's not true. The opening is because of other reasons that you have to look into. The second thing is the fiscal note, like everybody is talking about. In the note, it said that an average PBM was making $7 per prescription on spread pricing. $7 into 12 and 2 prescriptions per person, a PBM is making $168 on one patient. That's more than what the doctor makes. And these PBMs, like Shireen said, do not fill the prescription, do not stock the prescription, do not counsel. They do nothing. They're just like Visa, MasterCard, and Discover. All they do is transactions. And they are being paid more than a doctor, more than a pharmacist who sees the patient 12 times a year, more than the people who trust the patient's trust. I don't think that's right. I think you should ignore, take into account the pass-through model that the health administration suggested and eliminate the spread pricing, and that should take care of the fiscal norm. Thank you for your consideration.
Thank you very much for your testimony. Do we have questions from the committee for this panel? While I give you guys a second to raise your hands, if that's your intention, I'll call up the next panel. Delegate Hill, let's hear your question.
Yeah, I just wanted to ask one of the two pharmacists, if you all told your patients instead to download the GoodRx, to purchase all their medications through GoodRx and outside of the PBMs altogether, would that help you? I know that I think the PBMs wouldn't like it, but I'm just asking, how does that work for you all?
If I can be permitted to ask, answer, can everyone hear me? I'm sorry.
Yes.
Yeah, there are instances where GoodRx might be a tool. It's generally for patients with much higher copays. So specifically for this bill, we're talking about MCO copays, which range in the $1 to $3 to $8 range. Certainly with Part D programs where patients may have sometimes a $435 deductible, GoodRx might offer, and other discount programs actually often come in lower than the insurance benefit. And in the MCO marketplace, the copays are low, and I don't believe it would help them.
And does it help you all when you do that? That's what I'm trying to figure out.
You're talking about with GoodRx in the sometimes. I mean, again, sometimes it does, sometimes it doesn't. The problem with GoodRx is often it won't apply towards the patient's deductible. So it can cause an issue where maybe they're saving $10, but they're not hitting that deductible amount, and that creates its own issue. But there are going to be instances where it's better for us and instances where it's not.
Excellent. Thank you for your answer. I don't see any further questions. So next we have Jennifer Bremen, and then we will hear from Penny Walker after that. Jennifer?
Hi, good afternoon, Madam Chair, Madam Vice Chair, distinguished members of the committee. Thank you for the opportunity to speak with you today. My name is Jennifer Bremen, and I come before you representing the Maryland Managed Care Organization Association. MMCOA represents the 9 managed care organizations that serve the 1.3 million Marylanders enrolled in the Health Choice program. The MCOs respectfully oppose House Bill 602. As you will read in our submitted written testimony, and as we have in prior sessions, we come to you with concerns regarding the bill's provisions and offer an alternative to implementing the measures proposed in the legislation. With all of the recent changes implemented with the goal of reducing the program's pharmaceutical spend, including the elimination of the spread pricing model, the implementation of the pharmacy appeals and grievance process, and the impact of the small rural pharmacy access fee included in the fiscal year 21 state budget, the MCOs respectfully recommend that the impact of these significant changes be examined and considered by this body before more sweeping changes are made. These 3 cost-focused pharmacy initiatives are in the early stages of implementation, and their impact must be evaluated and understood before more measures, including those proposed in House Bill 602, are adopted, perhaps to the detriment of the program's quality and service to our members. For these reasons, we respectfully urge an unfavorable report on House Bill 602. And as always, the MCOs look forward to continued collaboration with the state as we work to identify ways to improve access to affordable, high-quality care for all Medicaid participants. Thank you all for your time.
Thank you very much for your testimony. Next, we have Penny Walker.
Penny never joined us in the room after several emails. So.
All right, well, let's see if we have any questions for Ms. Bremen. Do we have any questions? I am looking for raised hands and I am seeing none. None. Wonderful. So that concludes the hearing on House Bill 602. Committee members, it is 3:25. So we will return at 3:55 for the final bills of the day. So that will give us half an hour to take a break, but we are going to go live promptly at 3:55 so we can give a sense of timing to the stakeholders here. Thanks so much.
Hey, okay, so
Hey, Melissa, thank you so much for all of your helpful texts. I really appreciate it.
Sorry about that, Ariana.
About what?
I asked that question and I thought it fit and it was totally out and I just didn't mean to throw everything.
No, you're fine. Don't worry.
Let me say that I believe that even though we're in recess, we're live streaming. So please be mindful of that.
Okay, it is 3:55 and I think we have most of the members back. Let me double check and make sure we're doing well. Yes, so as people are filtering in, let's just give them a minute and we will reconvene the committee with House Bill 603. And we have 4 bills left for this afternoon. So we'll do 603, 607, 709, and 819.
I get it. A lot of seniors are. I mean, that's all they have to live.
All right. Welcome back to the Health and Government Operations Committee. We are going to begin the hearing for House Bill 603, Delegate Kipke, Health Insurance, Pharmacy Benefit Managers, Explanation of Benefit Statements. Delegate Kipke.
Thank you, Madam Chairman and members of committee. This bill very simply would require a quarterly explanation of benefits to a patient, just like they get with their health insurance. Those explanations of benefits, often you look at those and you think, wow, look how that price changed there, what they billed and what they received. That's, I think, what a lot of people see. But I think that this would actually provide a level of transparency that could open a lot of eyes. It would provide a value to the consumer, and it's being done in several different states throughout the nation. One of the biggest problems with this whole prescription drug issue is the lack of transparency as it relates to pricing. It seems to me that it's intentionally confusing, and all of the confusion related to it has a lot to do with profit and not a lot to do with healthcare. And so I think this would be an important and easy step that could be taken to shed a lot of light. And I ask the committee for their favorable consideration. Thank you, Madam Chairman.
Thank you, Delegate Kipke. And we have 2 people signed up in support of this. So let's hear from Steve Weiner first.
Madam Chairwoman, members of the committee, my name's Steve Weiner. I'm representing Epic Pharmacy. I own 2 pharmacies in Baltimore City. Thank you for letting me testify, and I would urge the committee to support House Bill 603. Over the years, we have asked this committee and the legislature to tackle schemes, shenanigans, whatever you want to call them, and we've spread pricing is one where the pharmacies paid one amount and the insurers paid another, and the PBM is in the middle. We've asked you to tackle patient copay clawbacks where a patient pays a higher amount and then we have to charge them a $50 copay and the insurance takes back $40 from me. We've talked about DIR, GER fees, and we've talked about predatory audits by pharmacies and to pharmacies, and when the money's captured back, where does it go? Does it go back to the patient? All these things are symptoms that we're tackling, but they're symptoms of an opaque and confusing drug pricing system. In my written testimony, I got HIPAA permission to submit an EOB from a patient named Steve Weiner, me. And if you look and you're curious how sick I am, you can look at that. And every other provider, it says Maryland law requires CareFirst Blue Cross Blue Shield to provide policyholders with a summary of the medical claims in 2020. Every other provider is listed. And I list it and I show you, Jim Groshin, I paid him a $25 charge. CareFirst paid nothing. Maybe CareFirst is carving back $220 out of that $225. I doubt it. LabCorp of America, I know never to pay cash for them because God, look at their charges. But the point is, I can see it. Every other provider does it. I urge your support. There's no reason we have a middleman that everything's private. Let's shine some light on this opaque, dark practice. Thank you.
Thank you. Let's hear from Gerard Herpel. I'm checking to see if Mr. Herpel, I think I see him right there.
Sorry, I was muted. I'm sorry.
No problem.
I'll start over again.
Please do.
Good afternoon, Madam Chairwoman. Thank you for allowing me the time to speak here in favor of the House Bill 603. I own Deep Creek Pharmacy out in Garrett County. I'm also a board member of Epic Pharmacies. Basically, every other healthcare, as Steve Weiner, said, I get EOBs when I go to my doctor. I get EOBs when I go to my dentist. There's no reason why this segment of healthcare shouldn't have EOBs sent to the patient so they know what's going on. The beneficiaries would be able to see how much was being paid to all entities in a transaction, including whether the middleman is benefit from the spread pricing and their insurance providers and the pharmacies and who's charging what. I mean, this probably won't shine light on the GER and the clawbacks and stuff like that, but just an example of something I had last month with a patient who is in a clawback plan, but has like a $500 or $1,000 deductible. She had a prescription that she had a $285 copay, which all went towards her high deductible. When you calculate the GER, the pharmacy benefit manager was taking back $244 of that from me. I made a $5 profit. The patient had to pay $285 and $244 of it went to the PBM. She never knows it. She thinks I'm the bad guy. We have plans where I'll wrap up quickly, but we have plans where we're being reimbursed.
Take an extra minute if you want, because Delegate Kipty didn't use all of his time. So go ahead and take an extra minute.
But, I have plans where I'm being reimbursed below cost 80 to 89% of my prescriptions. And, you're just out here in Garrett County where you have a lot of more underprivileged patients that are on Medicaid. Not necessarily they're going to get EOBs, but, you're losing pharmacies. You have people now, pharmacy closed in Grantsville, Maryland. I'm in the central part of the county. There's people now that have to drive 15, 20 miles one way just to go to a pharmacy. And it's, let's shine some light on it. Let people know where their money is going. That's all I ask. Thank you. Thank you for the extra time.
Thank you very much. Do we have questions for the proponents of the bill? I'm waiting to see if any hands pop up. While we're waiting, I will let you know that we have a number of folks signed up unfavorable. So I don't see any questions for the proponents. The unfavorable panel is Matt Celentano, Mike Johansson, Camille Fesh, if she's back from the Senate, I'm not sure, Heather Cascone, and Kim Robinson. Who would like to go first?
Madam Chair, I believe Delegate Collison had a question. Sorry.
Oh, she does. I see her waving. Thank you, Delegate Collison.
My mouse is not working very well today, and it's not getting to the reaction button fast enough. Sorry. And thank you, Madam Chair. So I guess I have a question about, first of all, could I get a copy of what it looks like from another state, what the COB looks like from another state? And I know that I am in Silver Script, so I get a monthly statement on my prescription filling, and so it tells me how much the payer paid and how much I paid, and it annualizes over the year. So you're seeking with this bill to include, like in Silver Scripts, and to how much the PBM was paid and how much the pharmacy was paid. So that EOB that I get from Silver Scripts would include all that information. Is that what you're looking for?
If I may answer, your EOB with Silver Script is slightly different because the payer and the PBM and the pharmacy are probably all the same. Silver Script is owned by CVS Caremark, so they're the payer. They're also the pharmacy benefit manager. So let's look at another relationship that would be common in Maryland. You would have Care First of Maryland is the payer or the insurer, and you would have CVS Caremark, just as an example, that's the most largest one. They are the pharmacy benefit manager. The way the bill is written, the patient would get an EOB. It would tell them what their copay was. It would tell them what I asked for. Maybe I'm unreasonable. It would tell them what the CVS Caremark paid the pharmacy, and it would tell how much Care First paid CVS Caremark. So just like the EOB where we get with doctors, every entity involved shows their payment. The difference with pharmacy claims is it's the only profession where we, or I shouldn't say only, one of the few where we have sort of another entity wedged in the middle of healthcare between the payer, which is Care First, and the healthcare provider, which is the pharmacy. Your EOB with Part D is different because it's showing what the pharmacy billed, and I believe it shows the copay. I don't believe it shows the payment to the provider. Okay, but your medical ones with Care First do. Your ones with your dentist do. Your one with your podiatrist and your meditation person all do.
So may I follow up, Madam Chair, quickly? So we could envision something that says, I had this medication. This is how much was asked. This is how much the plan paid. This is how much I owe. So it would tell me how much the pharmacist got, but it wouldn't tell me how much the PBM got. So you're saying add
the
that.
way the legislation is written, it says how much did the pharmacy ask and get paid? How much did the payer, like the insurer, like Care First, pay? And then it says how much did the pharmacy get reimbursed as well from the pharmacy benefit manager. And I'm sure it's all wonderfully proprietary.
So the payer, though, would actually be responsible for this form. It's not going to be.
I believe the way it's written, it says the pharmacy benefit manager has to provide it. However, the data points are there of what has to be on there.
Thank you. Thank you, Steve. Thank you, Madam Chair.
Absolutely. Do we have any more questions for this panel? I am seeing none. So let us move on to the opposition panel, and I'm going to ask Heather Cascone to go first.
Sure. Thanks, Madam Chair. Members of the committee, Heather Cascone for PCMA. HB 603 requires PBMs to provide beneficiaries an explanation of benefits, or EOB, that outlines information regarding the drug claim. There are a few aspects of the bill that are concerning for PCMA. First, the EOB would require that PBMs disclose to the patient the pharmacy's actual reimbursement amount. Why does this information benefit the patient as a consumer of healthcare? It doesn't. The reason every other aspect of healthcare has an EOB is because every other aspect has a billing system that happens after the point of sale. Pharmacy claims process in real time at the pharmacy counter at the time of purchase, unlike medical benefit claims that happen after the service is provided. PBMs have created real-time benefit check tools like websites and apps that allow patients to learn meaningful information about their drug purchase in advance. You can access information about how much your share of the drug's cost is and how much the plan would pay to cover the remaining cost, even before you go to the pharmacy counter. An EOB would provide no other meaningful information in the patient's decision-making, and certainly not in a retrospective format when it's already been made available beforehand. In addition, reimbursement to the pharmacy factors in no way into what the patient's cost responsibility actually is. Perhaps most importantly, though, and I know I've discussed this with the committee before, a reimbursement level is a competitively sensitive piece of financial information. The Federal Trade Commission has warned clearly that whenever competitors know the actual prices charged by other firms, tacit collusion may be more likely and thus higher prices. Not only does this proposed EOB risk pharmacies learning each other's reimbursement pose a risk here, but frankly, competitor PBMs, my own members, seeing how much they reimburse other networks could have anti-competitive effects. And while I suspect that's not the intent, it's for these reasons we request and ought not to pass on 603.
Thank you very much for your testimony. Let's hear from Mike Johansson.
Thank you, Madam Chair. Mike Johansson on behalf of PCMA, and just a couple comments to add to Heather's. This is a very good example of a bill that could be about data sharing or the process of a plan. It doesn't really regulate rates. So getting back to the very first bill we had on PBMs today and definition of purchaser, here's an example of a bill where we would believe that you can apply it to ERISA plans. And I'm not suggesting you are, but it's just an example of one of these thorny PBM issues that exist in today's law that relates back to that first bill. Just thought it was an interesting component. Secondly, Heather's right. Consumers know what they're paying. EOBs are an antiquated way of telling health plan enrollees what their share is versus what the doctor bills as his usual and customary fee. And it's a way that, you know, in the end, once the doctor submits and gets approval, when they see if he's covered, see what the benefit arrangement is, what type of service it is, it's so complicated on the healthcare side that the EOB is an essential piece of information. Here, this bill is just creating noise with no real benefit for the plan member. I'd also like to mention that to the extent that they're trying to get at what the payer has contracted with the PBM for, and whether or not the PBM is passing the full price on to the payer or not, is another level of contracting here that, you know, we didn't talk about. Heather talked about the confidential information between the PBM and the pharmacy, but that contract between the payer and the PBM is also highly proprietary, and that could lead to very negative issues with respect to competition. So we oppose the bill. We don't see the benefit in it. If you simply want us to pay pharmacies more, you've got other bills on this list that would get to that, and you'll see what the costs of those really are. Thank you.
Thank you for your testimony. And I don't believe Camille Fesh is back from the Senate yet. Is she not here yet?
She's on live in the Senate right now.
Okay, well, we'll hear from Kim Robinson then. Kimberly Robinson.
Thank you, Madam Chair, members of the committee. Again, Kimberly Robinson on behalf of Cigna. I'm here respectfully in opposition to House Bill 603. I'm going to try to just add to the information that Ms. Cascone and Mr. Johansson have shared. We do have concerns with this bill, and that is also from the perspective of a carrier. Unlike carrier EOBs, this bill does put into it additional elements of information that are not really aimed at educating the consumer. The cost between me as a carrier and my PBM isn't germane to the experience of the consumer. It is in some ways looking to put in a public sphere information for a really different purpose, as opposed to the education an EOB is intended to provide. As you heard from Ms. Cascone, part of why historically there have not been EOBs for pharmacy is not because it's not been deemed important, it's because of the different nature in how those claims are processed being done at point of sale. For that reason, many pharmacies do list, on the receipt, you'll see the retail price, and then you'll see what your cost share was, as a way to give some transparency, at least as to what that person would have paid out of pocket, as opposed to what their share was, whether they're paying the full freight because of a deductible, or whether they're paying a copay or co-insurance that's been reduced because of their benefit plan. But all of that is still different than what's being proposed in the proposal before you, even if we're comparing it to health plan EOBs. I also wanted to correct one comment. The suggestion that the only space in healthcare where there may be a third party who is helping to administer benefits for a carrier is completely inaccurate. It doesn't just happen in pharmacy. There are lots of spaces, and that information is still contained in the carrier EOB. Those individual entities that may have a hand in how those services are being delivered are not the ones who are preparing the EOB, as this particular bill would propose. And then lastly, an additional thing I wanted to put on the table is that in 2020, specifically in November, the tri-agencies of the federal government passed, can I just finish my one sentence, Madam Chair, just really quickly? The tri-agencies of the federal government, which is the IRS, the Department of Labor, and HHS, passed what is called the Transparency and Coverage Rule, which is going to have a disclosure provision for consumers to create better transparency about costs. This EOB bill doesn't line up with what's going to be required to be disclosed by the federal government, and we think that that's an unfortunate timing issue for when this bill was introduced, but an important disconnect. And so I hope to have the opportunity to talk to you a little bit further about why we think that also makes this bill unnecessary.
Thank you very much for your testimony. And we have one more person to hear from, which is Matt Celentano, and then we have some questions. Matt?
Good afternoon, Madam Chair, members of the HGO Committee. I'm Matt Celentano on behalf of the League of Life and Health Insurers of Maryland and America's Health Insurance Plans, or AHIP, unfavorable today on House Bill 603. This bill is a bit confusing to the perspective of the carrier and the consumer, as we're not really sure why we need this. Consumers already get this info at the point of sale, as opposed to the medical benefit where it's sent to you. I think everybody is familiar with those EOBs. But we would suggest that there are more effective ways to get to the consumers, if that's the intent, to get them the info they need. And a good example of that would be that pretty much all the carriers now have an app where the pharmacy information is already provided to them at basically the point of sale. This bill charges the PBM with sending details of your health plan to the MIA, but it doesn't track with what carriers already provide in the EOB. So to add on to the comments of my friends from PCMA and Cigna, we urge an unfavorable report on House Bill 603.
Thank you very much. We have a question from Delegate Cullison.
Thank you, Madam Chair. And I guess I just want to ask, so I guess I never thought that PBMs actually had the patient information. I thought that they were reimbursing pharmacies, based on, claims, but I didn't. Are PBMs themselves keeping the patient information so that PBMs could send me independently an EOB?
Yes, included in the claim detail is HIPAA protected patient information so that the PBM can accurately match up the patient to the plan sponsor via the member number and their name and date of birth, and make sure that it's attributed to the right plan when we receive that claim detail.
Okay, all right. Thanks. I never thought of that aspect of it. So thank you very much.
Delegate Hill.
Thank you, Madam Chair. I guess the question is, I want to make sure I heard correctly. two things. Ms. Cascone, I guess you can answer, since it's only one question for both parts, although Ms. Johansson had the second. You said that this kind of disclosure would encourage collusion amongst pharmacists, but pharmacists don't control what they get reimbursed. So I'm a little unclear how this would, it would if they actually got paid what they charged, but since they don't, I really don't see how that applies. If you could explain that. And then it was also said there's no benefit to patients in knowing what their copay goes through, what the charge was, and what additional fees are being paid to cover their medication. So I'm confused about that, because I would think it is of benefit to know if it's $200 for this particular drug and I'm paying $50 or I'm paying $200, if that's going to pay for the drug or it's going to pay for some other coverage. So if you could clarify why those two statements were made, I'd appreciate it.
Sure. I think I'll take your first question first regarding what constitutes collusion in this situation. Pharmacies, in this instance, it's confidential what the pharmacy's reimbursement is, confidential information to that pharmacy. So if I own a pharmacy and you own a pharmacy, we cannot know what each other are reimbursed in a given claim. Knowing that information would be anti-competitive. Likewise, in the same way, my PBM and Mike's PBM, knowing what we're reimbursing the pharmacies in our network could result in higher prices, because we might price set and collude if we knew what all of our competitors were paying other pharmacies. I hope that answers your question with regard to the collusion issue. It's not so much what the pharmacy reimbursement level is or isn't, but rather these market participants being made aware of what their competitors are being reimbursed that poses the anti-competitive threat. To your second question regarding pharmacy reimbursement and patient out-of-pocket costs, patient out-of-pocket costs are set at a predetermined level regardless of what the pharmacy's reimbursement is. Drug costs go up and down on a very frequent, as much as weekly or daily basis, but your copay will always be your copay based on what the cost of that drug is at any slice of time. And so one is sort of unrelated to the other. A patient's responsibility in terms of what they pay out of pocket will never be connected to what the pharmacy, how they buy that drug, what they're reimbursed by the plan or the PBM. The patient's responsibility is static, whereas that reimbursement level could go up or down, depending on market dynamics. Did that answer your question?
It was an answer. Thank you.
Yeah, the next question is from Delegate Bandari.
Yeah, thank you, Madam Chairman. I'm still not convinced, as we have been hearing for years, that poor reimbursement that have been threatening local pharmacies for years. In this light, this bill at least advocate for the drug reimbursement transparency. Mr. Johansson, if you could help us understand why this transparency is not good for peer payment, proper representation of generic brand drugs, and plus they can monitor any fluctuation. I don't think it harms consumer. Don't you agree? Would you respond to this?
Well, I think transparency with respect to how much the pharmacy is being paid is already in the hands of the pharmacy, right? So why would an individual consumer who visits a pharmacy be benefited by understanding they're going to get what their copay is, they're going to know what the pharmacist's retail price was. What does it matter how much the PBM reimburses the pharmacy? How does that benefit the actual consumer with respect to their plan? This bill goes further and then says that we'd have to disclose what the carrier's arrangement with the PBM is, which is now another level of kind of this confidential financial information. The individual pharmacies, when we talk about why this information is so proprietary, 80% of the individual pharmacies contract through PSAO organizations. 75% of those contract with the three large PSAOs that are all owned by wholesalers, people who sell pharmaceutical drugs. So these aren't individual contracts. These are largely contracts with thousands of pharmacies and the PBMs. So sharing that information among these large negotiators is not in the interest of keeping prices down. And that's the FTC's view, it's not just PCMA's view. So we just don't see why an individual consumer would benefit from knowing whether the pharmacy lost $5 on a particular prescription or made $5 on a particular prescription. That doesn't seem to be something that the consumer needs to know.
Thank you.
And the final question on this bill goes to Delegate Johnson.
Thank you, Madam Chair, and thank you, panel. Heather, this question is for you. You talked about a competitive market. Could this not have the opposite effect and create a competitive environment where the plans know what the other plan is reimbursing? As the same principle that we see in gas stations and just about every other retailer in our country?
Delegate, I can only reiterate what the FTC has opined, and I would be happy to share their more broad interpretation of these types of proposed legislation. They've weighed in on various bills across the country over the last several years, and when asked, have reiterated their opinion about the risk to competition. I'd be happy to follow up and share their letters to legislators with you.
All right, thank you. Thank you, Madam Chair.
Absolutely. And that is the last question on this bill. So that concludes the hearing on House Bill 603. And we are going to move on to House Bill 607. And I believe we are, this bill is jointly assigned with appropriations. So we are going to be joined by Delegates Young, Delegate Henson, and Delegate Mangione. So I think we're getting them in the room now. There they are. Welcome. Welcome to HGO. Delegate Kipke, would you like to present your bill?
Thank you, Madam Chairman and members of committee. House Bill 607 would take action on something the committee recently did, in that last year the committee enacted, the General Assembly passed legislation that would put the state employees benefit plan as it relates to pharmacy out for a reverse auction. And in that process of putting it out for a reverse auction, we're mimicking what took place in New Jersey, and I hear is moving beyond, is continuing to spread around the country. It forces a true competitive platform for PBMs and/or third-party administrators to compete on the actual cost of a therapy. The one component that is missing in that is, in my opinion, addressed by this bill. We have to ensure that the pharmacies, the pharmacists who are doing the work to deliver the treatments to our Marylanders are reimbursed adequately so that they are not forced into bankruptcy, which is what we're seeing over and over again. So what this bill would do is it would say, when you develop the bid, which won't happen until next year, 2022, when you put that bid out for these companies to compete on, make sure that they include, one, transparency, but a defined reimbursement rate. And again, this is just for the state employees plan. Currently, the state employees plan, I've learned, only reimburses a pharmacy 35 cents for prescriptions. However, the state did a survey a few years ago and determined that the cost to exist and to deliver prescriptions to patients is more like $10 or more per prescription. So Maryland is certainly not doing their part to look after a healthy ecosystem with pharmacy for our state. The bill does, again, have a very big fiscal note, about $40 million if it were implemented at the current rate. But I'll point out one of the reasons and one of the motivating factors to move towards this reverse auction is the fact that we learned through a third-party evaluation that in the current plan, the PBM is pocketing through spread pricing over $70 million. So my simple math would indicate that the state would still finish ahead once this thing is fully implemented. In addition to that, if it's anywhere like what was seen in New Jersey, we'll have even more savings by forcing a competitive bidding process. So I think it's important that, you know, we've done what we've done to move forward with that. I just don't want to see this last component continue to be ignored. And this, I believe, is an important step to protecting community pharmacy. And look, I'm sure these folks are negotiable as it relates to the reimbursement rate. I mean, right now, they're just being squeezed out and they'll eventually vanish in our state. So we have to do something. And I believe this is an important step and an important moment because we're moving in a new direction going forward. Thank you, Madam Chairman, and ask for your thoughtful consideration.
Thank you, Delegate Kipke. And we have two people signed up favorable, Steve Weiner and Gerard Herpel. So let's hear from Mr. Weiner first.
Madam Chairwoman, members of the committee, thank you for letting me testify for Epic Pharmacy. Also, Delegate Kipke, thank you for supporting this legislation, among others. You've been a champion of small business, and we appreciate it. I submitted written testimony, and the reason I think we ought to put this floor in of NADAC plus 1049 is I think it'll save the state money. And I put a link on my written testimony, the hyperlink to the Myers and Stauffer study that Delegate Kipke mentioned that references the spread pricing. And one thing no one talks about is on page 14 of that study, PBM affiliated pharmacies were paid on average $148.89 per claim, and non-affiliated pharmacies were paid on average $47.69. In the current environment we have, it's if you own the vertical integration, you do great, and if you don't, you get squashed. And this defines every prescription will get paid at a minimum of NADAC plus 1049. So now you shouldn't have these big spreads between $148 average payment and $47 on an average prescription. That divergence will save the state money and it will be transparent. It's on my testimony. You can look it up yourself. The fiscal note mentions the reverse this will prolong the reverse auction process if this bill passes. The fact of the matter is anyone who sat in on that bill last year when the representatives from New Jersey testified, and last sentence, heard the questions from this committee and many questions. Can we put in a pharmacy rate? And New Jersey responded, yes, you can, but we did not. So this should not come as a surprise, and there should be contingencies for the state of Maryland if this bill passes with respect to timing. Thank you, and I urge a favorable report.
Thank you for your testimony. Let's hear from Gerard Herpel.
Thank you, Madam Chairwoman. Gerard Herpel, Deep Creek Pharmacy in Garrett County, board member of Epic Pharmacies. Speaking in favor, this has to do with a lot of numbers, and I don't want to glaze your eyes over because Steve's already presented, the differences in affiliated and non-affiliated pharmacies. One of the things to remember is that, especially out here in Garrett County, Allegheny County, and rural areas like the Eastern Shore, you have a lot of state employees that are spread out, have, distances to go to their pharmacies, distance to go to where, they work and play, if you will. As all we're asking is to put this floor in. NADAC is out there. The state addictions program, the mental health program that's carved out of the MCOs go by these cost of dispensing, the NADAC, and it's fair. We all make a reasonable profit to keep our doors open. So, I mean, you know, that's what we're looking for, just to things to be fair, have a fair floor to start with. Thank you.
Thank you very much for your testimony. Just a notice to the visiting members from Appropriations. If you have a question, you can raise your hand in the raise hand feature under participants. We have a question from Delegate Hill.
Thank you. Delegate Kipke, as I read the text of the bill, it requires that in the bidding process that a dispensing fee that is offered by the bidder be disclosed and that it be based on the actual cost, but it doesn't say it has to equal. So it seems to me that the fiscal note is sort of suggesting it would match, but a bidder could say, I'll pay 50% of the dispensing fee if I'm reading it right or something, but it at least allows in the bidding process to know what that dispensing fee might be and for that to be considered. Am I reading that right? Or does it require that it match a particular dispensing fee? Because there's a wide range between $35 and $7. They might say, I'll give you $5. They might say $4.
I think it requires, we'll double check, but I do believe it requires on NADAC plus, which I think it's nationally average. I can't think of what the acronym stands for, but it's basically an average price that is sort of an independent source that publishes the prices to reimburse for the actual cost of the drug, plus whatever the state determines is the reasonable reimbursement for the professional services. I could have that wrong, but I think that's the way it works. And it would require that whoever wins reimburses at that rate, and there's true transparency to make sure it's happening. And to respond to the part about the state getting slowed down and all that, you know, they really should be doing this now. I mean, it's irresponsible, and we're going to meet with the department after session, but it's irresponsible for the department to put forward a bid where you don't know what the reimbursement's going to be, or to require some reasonable reimbursement so that folks can survive. I mean, the last thing we want is for this bidding process to further squeeze pharmacy. They're obviously on the losing end of all of this, and the folks that have the highest profits are the ones that really need to be squeezed in this whole scenario. So hopefully that answers your question.
Yes, excellent. So I don't see any further questions for this panel going once, twice. We do have a panel of favorable with amendments. So first we'll hear from Jim Doyle and then Sharon Joseph. Jim?
Jim, you're on mute. Hey, Jim, you're on mute.
I see him reaching, so.
I'm sorry. I'll get the hang of this eventually. Jim Doyle on behalf of Independent Pharmacies of Maryland, we support the bill. With respect to the amendment, the only amendment we were suggesting, and I think it's been covered, is that the NADAC price for the price of drugs should be included in this bill along with the dispensing fee. With respect to the bill itself, we agree entirely that it simply is not sustainable for pharmacies to continue to, under another program, to dispense prescription drugs at a loss. And for this reason, this has to be corrected. And again, with respect, as I made earlier in my point on 602, with respect to the fiscal note, I think that really the committee needs to keep in mind that PBMs are making fabulous profits out of this business to the detriment of independent pharmacies. And again, we've cited the Wall Street Journal article that takes a good look at this, and the rate of return from revenues to operating profits is at an extremely high level. There's money that is in this program, in the pockets of the PBMs, in the form of rebates, in the form of spread pricing. Those monies should be allocated equitably so that pharmacies can recover their costs and make a reasonable living and dispensing drugs. Thank you.
Thank you very much. Let's hear from Sharon Joseph.
Madam Chair and the members of the committee, it's Sharon Joseph again with Independent Pharmacists of Maryland. We support this bill with amendments. Like Jim was saying, we are all for savings, but it should not be at the expense of hardworking pharmacies so that the PBMs can line their pockets. For a small business to be sustainable, they must be compensated fairly. So this House Bill 607 would ensure that any PBMs who wants to bid on the state employee plan must agree to fairly pay pharmacies for the services that they provide for the state employees. So we are in favor of the HB 607 with the amendment. Thank you.
Wonderful. Thank you so much. Do we have any questions for these panelists? I'll give everyone a second to reach over if they need to. I'm not seeing any questions. So I am going to say that's going to conclude the hearing on House Bill 607. Thank you so much. Moving right along, we've got 2 left on our agenda. So we will move to House Bill 709, which is Delegate Krebs' bill, Pharmacy Benefit Managers, Drug Reimbursement Reporting Requirements. Delegate Krebs.
Thank you, Madam Chair. I have in front of you today House Bill 709. No surprise, it has to do with public health, PBM drug reimbursement reporting requirements. I know that this committee has been very frustrated over the years in trying to get to a solution. I don't know what it is, but I think we need to talk about transparency. And the first thing that this bill would do was require PBMs to report the costs of prescribed drugs to the insurance commissioner for all drugs that were reimbursed by PBMs to pharmacies below a certain amount. I won't get into all the details of the drug, of the bill, but it basically would give us some ideas of really what is going on. We've heard a lot of anecdotal situations where this would give a report, and it would provide needed transparency to the financial transactions between PBMs and pharmacies. You know, what are the differences? As we all know, the pharmacy's cost for filling a prescription is dependent on the cost that it pays to acquire the drug and the cost that it's reimbursed for dispensing the drug. It's pretty simple. It's not rocket science. So this legislation would allow us to see, the public and us to see, if and how often PBM reimbursements fail to fully reimburse a pharmacy for the 2 components, the cost and the dispensing. It's pretty simple. So I'm going to give the rest of my time to the proponents of the bill and just try to shed some light on what we're doing here. And I ask for your favorable support and ask the committee to please try to find some solutions for this very difficult situation that we've been in for years. I'll hand it over to my proponents.
Thank you, Delegate Krebs. Sharon Joseph, do you want to go first?
Yes. So my name is Sharon Joseph again, and I thank you for this opportunity. I'm here on behalf of the Independent Pharmacists of Maryland, testifying in support of House Bill 709. For the past couple of years, we've been telling this committee about how pharmacies, and especially the independent pharmacies, are being reimbursed below cost on an increasing percentage of claims, which is slowly forcing us out of business and out of the communities we are in. We are at the bottom of the food chain, and we are being squeezed by the PBMs on a daily basis. Yet we are the ones who face the patients, not the PBMs. So this House Bill 709 can finally shed some light on what is really going on by mandating the PBMs to report when they knowingly underpay pharmacies for the prescriptions they provide to your constituents. So this committee can finally see in black and white the after effect of a payer who is also the direct competition being put in charge of providing compensation to its payee. This trend of wiping out independence would potentially set up a healthcare and fiscal disaster for the constituents of Maryland. Regulations should not be for protecting big corporations. Rather, it should be for protecting the consumers. And for the PBMs who claims to be the best negotiators out there, it should be just a click of a button to produce such a report. If they claim otherwise, then their own statement of being the best is morally and fiscally bankrupt. This is also a chance for them to prove that they have nothing to hide. So we humbly request this committee to support HB 709 so that we can continue serving your constituents effectively.
Thank you very much for your testimony. Now we'll hear from Deepak Keeney.
Thank you, Madam Chair. Again, my name is Deepak Keeney. I represent Hillcrest Pharmacy in Frederick, another small pharmacy, and sincerely appeal to all of you to think about one thing. The work that you have done in the past has scared the PBMs. and they have come up with websites to discredit independent pharmacies. And that's true. We can send you information about this. They are putting up websites discrediting independent pharmacies, saying that independents are making a lot of money and they're well off and they're asking for more money. It's not true. They are doing anti-competitive practices. There is no firewall between their pharmacies and the PBMs. These kinds of legislations which promote transparency will expose that kind of practice. So if it is true, or at least it'll push them towards being true to their word. What I'm saying is, like, for example, if they find that across their network, their pharmacies are filling X prescription in a higher number, they might increase the reimbursement for that prescription and let the other prescriptions at a lower reimbursement rate. So their pharmacies make more money. So those kinds of practices might be happening, and this law will expose those kinds of practices. So they are doing anti-competitive practices and antitrust practices. They just don't want to admit it. I think this kind of laws will help putting one step closer to those kinds of practices. I'm sure, they will bring up the argument that this will raise costs, but I don't think so. If they are efficient, like Shireen said, they should take a click of a button to send that report across. I think you guys should continue the great work you guys been doing to help independent pharmacies, and I hope you find this favorably for this report. Thank you.
Thank you very much. Let's hear from Darren Nayland.
Darren hasn't joined us in the room after multiple emails.
All right, well, we tried our best, but we certainly heard from a number of people on this bill. So do we have questions for this panel? I'm going to give just a second just to make sure no member is raising their hands. I see none. Wonderful. Let's move on then to the panel, unfavorable panel. Heather Cascone.
Thank you, Madam Chair, members of the committee. I appreciate the opportunity to raise some potential issues with 709. NADAC, or the National Average Drug Acquisition Cost, is a voluntary national survey of pharmacies who are willing to self-report their invoices for drug dispensing claims to CMS. These pharmacies submitted invoices include prices that do not reflect discounts, rebates, or price concessions that the pharmacy may have received, and as a result are not indicative of the true cost of dispensing the prescription drug. Instead, they are artificially skewed to a higher rate. Because NADAC is self-reported, which means that pharmacies are not obligated to report it, nor are they obligated to report all of the invoices for all of the drugs they dispense, allowing selective invoices to be reported. Utilizing NADAC as a reference price, the state of Maryland would be comparing claims to the highest cost possible for the prescription drugs dispensed. Additionally, NADAC is recognized to be flawed in that it is a retrospective look at drug pricing that often lags so much that it can be inaccurate to current pricing levels. In a commodity-like market, drug prices can change on a weekly or even daily basis. A price could be completely irrelevant by the time it's reported to CMS and then used as the NADAC price. It's given these limitations and the fact that this proposal could arbitrarily skew prices higher, it raises questions as to who would like the state to use this model and why. At a time of escalating drug costs, PCMA would like to support policies that lower costs, not run the risk of escalating them. And so it's for these reasons that we respectfully request an ought not to pass on this bill.
Thank you very much for your testimony. Mike Johansson.
Thank you, Madam Chair. And again, just to follow up on a couple extra things that Heather didn't mention, I'm Mike Johansson on behalf of PCMA. So page 3 of the fiscal note on this bill references the same Stauffer and Meyer report that was previously mentioned on other bills. And NADAC is interesting in that the average of the wholesale acquisition cost in some cases, and here the fiscal note claims on the top of page 3, that the study found that the MCO, average ingredient cost, that the NADAC price was lower than the MCO's ingredient cost for 37 of the drugs analyzed, meaning the MCOs were paying slightly more for the ingredient cost. Now, this switched completely around on the dispensing fee, where the state at the $10.49 is paying a lot more than what the MCO pays for. So, when you get to ingredient costs, you need to kind of look at the current market. Secondly, when you're looking at the average, the NADAC average is brought significantly down because of the effect of the chain drugstores are in the same average pool as the independents. So there's been a lot of discussion in the past and some concern expressed by the members that the chains are able to negotiate better rates when acquiring drugs from wholesalers. So when they do that, the average of the cost actually goes down. So using NADAC on the ingredient side alone isn't necessarily a benefit. But let's take a look at the reason. The only reason to gather this information is to ask the question that was presented in Senate Bill 602 and in the most recent bill related to the State Employees Health Plan. Do you want to pay pharmacies more? And in the Medicaid, that question to pay NADAC alone is $100 million a year. And remember, the majority of that money would go to the chain drugstores, not the independents, as we know that's where most of the volume is. So you can have a question about reimbursing more. Someone always pays. And in this case, and in every other case, it is the payer or the health plan sponsor, such as the state employees plan, Medicaid, or the business who has a health product. So we oppose this bill as simply unnecessary.
Thank you very much for your testimony. Let's hear from Matt Celentano and then Kim Robinson. Matt?
Thank you, Madam Chair, members of HGO. This is Matt Celentano on behalf of the League of Life and Health Insurers of Maryland and AHIP, America's Health Insurance Plans, opposed to 709. I'm going to be brief. We are concerned about the precedent of publishing healthcare data. It's all sort of relative reporting using NADAC as the benchmark, and we suggest that it might be anti-competitive. It takes proprietary information and immediately puts it on a public website. We're worried that the release of this information could lead to price increases, which would have upward impact trends on healthcare premiums. And for those reasons alone, we are unfavorable or urge unfavorable on House Bill 709. Thank you.
Thank you very much. Kimberly Robinson.
Thank you, Madam Chair, members of the committee. Kimberly Robinson on behalf of Cigna, respectfully here in opposition to House Bill 709 for the reasons that you've heard from the other panelists. I want to highlight the point that Mr. Celentano made about this report. There are a number of reports that all kinds of healthcare entities who are regulated by the Maryland Insurance Administration provide them, and they are typically reviewed under our PIA in terms of what is proprietary or trade secret information. And this would absolutely fall in that category as we were talking about proprietary reimbursement rates that are being paid by pharmacy benefit managers on behalf of carriers in our state. This bill makes them, as Mr. Celentano noted, immediately public, which, harkening back to the conversation about the FTC's opinion of putting such information out in the public sphere, is absolutely considered anti-competitive. This would just utilize the state to hand to my competitor information that if I were to hand them, the FTC would come after me. And we do believe that that has all of the harm that the FTC believes would come from it involved. But secondly, what's odd about this report, because there are definitely transparency laws when it comes to PBM reporting that you can find from across the country. There's only one other state that has a law that looks like this. And it's odd in that it's benchmarked to this voluntary sample size is very small. There's 70,000 pharmacies in the country, and on average, about 400 report to NADAC, and that's creating this benchmark that in many ways is artificial. But also, this is not the way one normally tracks information. I appreciate the comments about our efficiency, but most businesses do not pick an artificial benchmark and somehow build our systems to peg to that thing. It's one thing to ask me a question about what I do. It's another thing to say, now take what you do and computate how it relates to something else that for you is not particularly relevant because it's not a true benchmark. And so it also lends a set of complications to try to do it this way. It's not providing the state any kind of real information or transparency. It doesn't call on the department to do anything with the information except become a public clearinghouse to put it in the public sphere. And that causes us great concern. And for that reason, we urge an unfavorable report.
Thank you very much for your testimony. Members, please raise your hand in the participants tab if you have a question. We do have one from Delegate Kipke.
Thank you, Madam Chairman. I am curious, well, I guess for PCMA, over the interim, was entertained by this campaign that somebody's putting on. I assume not PCMA, but maybe I'm wrong. I guess, Heather, is PCMA the organization behind this campaign that's going on that's attacking these independent pharmacies?
I'm not sure what you're referencing. Can you be more specific?
So on Twitter and on social media, there's a paid campaign that's defending PBMs.
Our industry association is responsible for defending PBMs.
And are you doing online paid advertisements to do that?
We have, over the course of many years, published information about PBMs and our relationships to defend our industry.
So
that's nothing new.
So the campaign that's going on that seems to, I mean, hey, it targets these community pharmacies, basically saying they're greedy. So is that how you're defending PBMs?
Our campaign is an informational one that defends our business for many years. As you're well aware, we've had a philosophical difference about how community pharmacy is surviving here in Maryland. We have often shared information about store numbers and financial health. We have a vested interest in making sure stores are viable, and we will regularly publish information that's factual.
So the marketing campaign that basically, I mean, what I'm reading in your marketing campaign would indicate that you're calling these people, these pharmacists, liars. So your association, are you lying? Who's lying? Are you lying? Or are these pharmacists who literally cry and are shutting down their stores, are they lying, or is your association lying?
Delegate, we obviously disagree about whether store numbers are going up or going down, both nationally and here in the state of Maryland. We have shared information, our own research and external research, that it seems has not been recognized. And so we have continued to share that information because we believe it to be the truth.
Delegate, we have one question, one answer. So
Oh, you're right. Just yes, finally, Madam Chairman. So did the two pharmacists that testify on this bill, are they lying about their inability? I mean, Shireen testified that she's run up her credit card, she's taken out a second mortgage. Is she lying? Delegate, or your association misleading the public?
No one's certainly questioning the credibility of any witnesses. We've worked with the independent pharmacies for a number of years. We know Steve and Jerry well. You know, we haven't questioned anyone's integrity. So
the marketing campaign, all I'm saying is the marketing campaign hosted by this trade association is misleading the public and defaming community pharmacists. And I thought this would be an appropriate time to ask about that.
We stand by any information that we're responsible for publishing. Thank you.
Thank you. Delegate Krebs, your question.
Whoops, I popped over there. Sorry about that. Thank you. I guess the question is for Ms. Heather again. We talked about, I've heard artificial benchmark, NADAC is really a self-reported average, is not indicative of true costs of the drugs. Using NADAC would represent the highest cost drugs. So you've named all these reasons why we shouldn't be doing this thing, but you haven't given us a solution. How do we get to the root of this problem? I mean, what we're trying to do is get rid of monopolies. And every year we meet, there's more monopolies that are buying up, you know, PBMs, and insurance companies now are all, so it's all you gotta do is look in the Wall Street Journal. So this committee in Maryland, we're trying to protect our local pharmacies and stop these monopolies from, I mean, all you gotta do is look and see the profits that are being made in the monopolies. So what would you suggest that we do as a committee to get to the bottom of just giving the local independent pharmacies a fair shake, a fair, being able to run their business? What is your solution if NADAC and the self-reporting, I mean, this reporting mechanism, what is the solution that you would have us do?
Sure, thank you for the question, Delegate. I can tell you that I don't think this solves that problem of well, you mentioned monopolies. I don't think this bill solves or even comes close to addressing that issue. And we would be happy to reconvene with the committee and you specifically about how we can solve this problem together. This bill, unfortunately, is just such a small slice of information that's not, it's just sort of artificial. It doesn't really represent a true or fair benchmark for reimbursement.
But we'd like to get that true and fair benchmark, and that's what we're trying to get to. If you could be helpful with that, we wouldn't have to see you every year.
Understood.
We do have a problem we're trying to solve. We're looking for you to be help be part of that solution. Thank you.
I think Delegate Bagnall's question was answered, but Delegate Johnson still has one.
Thank you, Madam Chair, and thank you, panel. This question is for Heather, and it's kind of a follow-up on Delegate Kipke's question. Why is it your association has funded a campaign which you say is informational, but yet you have opposed every single piece of legislation this body has put forward to try to get information and be transparent?
With respect, Delegate, we've testified before this committee for a number of years. We worked on many pieces of legislation together, both at the legislative level and at the regulatory level. In fact, PCMA was very supportive of a piece of legislation this committee approved last year, which created a level of transparency on pharmacy services administrative organizations, or PSAOs, which gave the state more transparency into all of the parts of the drug supply chain. We're trying to put forth information that helps everyone become smart purchasers and everybody understands the truth of where the money flows. And we have supported those types of pieces of legislation. In fact, we've been instrumental in them. And so while we do oppose this particular piece of legislation because we don't think it accomplishes that, we have been supportive in the past.
And just to follow up the last part of the question, we've had 5 pieces of legislation today that speak about getting information and transparency that you have opposed all of those today. Can you just expand on your answer?
Yeah, I think I'd refer back to my previous question and answer that you and I had on the last bill. Part of the reason why we've opposed some of these pieces of legislation is because of the anti-competitive effects of it on the marketplace as a whole. And so we don't want to create a scenario where prices go up when the intent is to have prices go down.
Thank you for your answer. Thank you, Madam Chair.
Absolutely. Delegate Bhandari.
Thank you, Madam Chair. Quick question. How does this committee know how many of independent claims are reimbursed below the pharmacy cost in a given quarter to mitigate these harmful practices that we have been discussing? Is there any way that we know, this committee know how many claims are reimbursed below the pharmacy cost in a given quarter?
Delegate Bhandari, this is Mike Johansson, if I could answer. I mean, the Maryland Medicaid, which represents 25% of Maryland citizens, did an extensive audit. And that audit demonstrates, as I mentioned, in many cases, the total reimbursement under fee-for-service Medicaid is higher, which is NADAC formula, than what is done by the MCOs in the free marketplace, where it's contracted and negotiated and paid by the PBMs. So for 25% of the state's population, according to the bill that you guys heard earlier today, it would cost $100 million to reimburse pharmacies at NADAC through the Medicaid fee-for-service system. Under the state employees plan, it would cost $20 million more at a minimum to reimburse those pharmacies higher. So all you need to do is extend those out to see what the rest of the marketplace would cost in order to pay the pharmacies more. The data exists. You don't need to collect it again in order to prove the point that PBMs reimburse pharmacies less than what Medicaid does under NADAC.
Thank you.
Let's hear from Delegate Pena-Melnick.
Thank you. So every year we're here, and I really have a hard time believing that the pharmacists independent pharmacists that we have heard that have been in tears in our committee, that they're making this up. It would be different if it was one person, 2, 3, but we have had our hearing where we have had all these white coats. So many have left business for the day, to come to be heard. So the truth lies in there. I had a fiscal note, and one, you told Delegate Johnson that you didn't think you opposed this bill because you didn't think it did what it was intended. Well, that's not a reason to oppose it because the bill actually provides transparency. And if I look at the second page of the fiscal analysis, it says that, you're saying that the information is proprietary and confidential, but it says here, however, a narrative in the 2018 Joint Chairman's report requested the Maryland Health Department on various aspects of pharmacy reimbursement. MDHA response summarized MCO PBM costs for example of drugs according to a low, high, and average rate across all MCOs. So is this when it's convenient? I mean, it's why could they do that there and we cannot do it as this bill is requiring? Can someone answer that for me, please? And that's page 2 of the fiscal note, the last paragraph.
Yep, Delegate Peña-Melick, it's a great question. And under Medicaid, this information is available. The MCOs are obligated to provide to the state health department for its informational purposes and for rate setting purposes, any payments that they make under any request from the health department. But if you look on the same fiscal note, the next page, page 3, in the middle of the page for additional comments, MDH advises the information PBMs are required to release under this bill is considered proprietary. So in the private marketplace, it is more necessary to protect this commercial information because of the competitive marketplace. In Medicaid, where Medicaid is already entitled to it, they kept it confidential and they evaluated.
Yeah, it seems to me that is in the additional comments, and that's the Department of Health's opinion. I wonder, have we ever sought a general opinion on this? Anyone?
I'm not aware, but proprietary information is proprietary. The question is how you use it.
Yeah, but it's up to interpretation because obviously in this fiscal note, it's not that clear if you could do it for one and not the other. So I think, I would like to get an Attorney General opinion on, what is proprietary. Thank you, Chairman.
Thank you. So that is the last question on this bill. So that concludes the hearing on House Bill 709. And we will move to the last bill of the day, which is House Bill 819, also Delegate Krebs, entitled Pharmacy Benefit Managers Prohibited Actions. Delegate Krebs. Delegate Krebs, up there.
Trying to find my mouse. Thank you. Thank you, guys. And thank our committee for, I know our committee members are so passionate about these bills for our local independent pharmacies, but House Bill 819 is another attempt to find another solution. It's Pharmacy Benefit Managers Prohibited Actions. If we can't get transparency, let's just come out and prohibit some of these things that we think are problematic. So what does this bill do? It basically adds to the list of statutory prohibited acts by pharmacy benefit managers. And they're listed here, there's 5 of them. I would diminish reimbursement to a pharmacy based on patient outcomes. It would prohibit engaging in the practice of spread pricing. It would prohibit denying the right of a pharmacy to participate in a plan if the pharmacy agrees to the terms and conditions of the plan. It would prohibit setting different fees for a copay based on whether the pharmacy is an affiliate of the PBM. And it would also prohibit requiring that the beneficiary of a plan use a mail order pharmacy. Why do we need this bill? We've already talked about that for half of this day. We believe, I think many of us in this committee believe that there's some unfair, anti-competitive, anti-consumer practices by PBMs. And they're becoming monopolies and they're creating unlevel playing fields both for independent pharmacies and for consumers. And our independent pharmacies are part of our communities. And when they fail, it's a support mechanism for all of our communities, and they provide services that some of the commercial pharmacies don't. And I don't want to get into that, but I think we all agree that our independent pharmacies are very important parts of our communities for many reasons. For instance, one example is PBMs have threatened to reduce reimbursement to a pharmacy based on patient outcomes. They've engaged in spread pricing. And they've done all of these things, and we don't necessarily think they're fair. Or are they doing that across the board with their own in-house pharmacies as well? Some pharmacies have been denied the opportunity to participate in a prescription plan, even if the pharmacy is willing to accept the terms and conditions of the plan. Consumers want the choice of where to go to get their drugs, to get their prescriptions filled. Some PBMs have different copays for different pharmacies, and having low copays for pharmacies associated with PBMs is discriminatory and unfair and should be the same for all pharmacies. And finally, it's unreasonable to force all pharmacies to provide mail order. This should be the choice of the consumer and not a requirement imposed by PBMs. I mean, many people want mail order, but also many people want to talk to their local pharmacist, and that should be a choice. So I urge the committee to consider these 5 prohibitions to add to the list, to try to level the playing field for our independent community pharmacies. And I ask for your consideration of these 5 prohibitions to be added. Thank you.
Thank you, Delegate Krebs. Let's hear from Tom Wieland.
Okay, Tom Whelan. I own and operate Ritchie Pharmacy, a small independent pharmacy in Brooklyn Park. And indeed, I am in favor of HB 819. This bill has several components, but since I only have 2 minutes, and I apologize, I always get very emotional when I do these hearings. I just want to clear up some of the garbage we've heard today from the dark side on just about every one of these bills. And we can sum it up in 3 simple sentences. Confuse the public, assume we're all dumber than dirt, and for God's sake, hide the profits. And one of these is in mail order pharmacy. There is no pharmacy out there who does not think that mail order pharmacy is needed. There's lots of areas where there's sparse pharmacies, there are shut-ins. What we're against is mandatory mail order. Last week, as I'm sure many of you on the panel, I got a Christmas card last week that was mailed back in December. I sent my brother and his wife in Florida a flowered centerpiece via UPS for Christmas. He got it the 2nd week in January. All the flowers were dead and wilted. Thank God none of these were prescription medications. No one can convince me that it is more efficient, safer, cheaper, timelier, and better for patients to be required to get mail order prescriptions, especially for those who live within a few blocks of my pharmacy. They get their prescriptions delivered by me, or they pick up their prescriptions while shopping for groceries or over-the-counter medications. Local pharmacies know their patients personally. When they come into my pharmacy, patients in casual conversations will ask me or tell me about their problems or interactions they may be having with their medications, as well as any other over-the-counter medications they may be purchasing or taking at the time. I can tell them, especially if they're taking something like pravastatin or a statin, and they come up and they buy Tagamet or Prilosec or Zantac, and I know that these things interfere with their statins. This is not going to happen when they get stuff through the mail. Nothing is better than a one-on-one patient-to-pharmacist interaction, and it won't happen in mail order. Thank you for my time.
Thank you.
Madam Chair, I just wanted to mention, I'd like to give my extra time. I think the extra 3 minutes, give my time to Mr. Doyle, if that would be appropriate. Thank you.
Absolutely. Mr. Doyle, we're going to give you Delegate Krebs extra minutes as well as your testimony time.
Oh, thank you very much. Jim Doyle on behalf of Independent Pharmacies of Maryland in support of this bill. And I think Delegate Krebs put her finger on it in terms of what we're trying to do here with this bill, which is to eliminate anti-competitive practices and anti-consumer practices. And in addition to take away some practices that appear very strongly on their face to attempt to favor PBM affiliated pharmacies over independent pharmacies. So to run through just quickly the 5 points, and starting out with the prohibition that would prohibit a reduction in reimbursement based on a poor patient outcome, that doesn't seem to ring, with respect to common sense, that the pharmacy in filling a prescription should have its reimbursement reduced because of how a particular patient may do on that prescription. There just doesn't seem to be any reason for that. With respect to spread pricing, we know from the Myers and Stauffer report that a year or two ago, that was in the neighborhood of $72 million just on the Medicaid side. That's something which, can certainly be eliminated and would certainly allow additional money to be allocated toward a fair and equitable redistribution of what's occurring here between PBMs that are making all these profits and independent pharmacies, which are really struggling and taking out loans and second mortgages to try to keep the store going. So that's something which should be eliminated. There really is no justification for the MCO paying the PBM one price for a drug, and then the PBM turning around paying a lesser price to the pharmacy and pocketing the difference as a profit to the PBM. With respect to copays, I think it's been noted that there has been a practice of paying different copays. One copay may be paid at one amount to an affiliated pharmacy, and a higher copay is assigned to an independent pharmacy. Well, clearly, the difference there is to make it more attractive for a consumer to go to the affiliated pharmacy. And again, this really plays right into what is the point of that? And it seems that it would be to protect the affiliated pharmacy at the expense of the independent. Any willing provider. This is not a new concept, any willing provider pharmacy. And as a matter of fact, looking at this, it turns out that there are, by my count, 34 states in the country that have this in one form or another. What this does is simply say, look, any pharmacy can join the plan if they're willing to do it on the same terms and conditions. It doesn't affect the ability of the PBM to negotiate. That's put out there, but it's not explained how that would actually occur. It's just put out there as a statement with no explanation. No, they can negotiate, but let's let any provider that's willing to agree with those terms participate, as many other states have already done. And again, this appears to be nothing more than an attempt by PBMs to protect affiliated pharmacies from competition by eliminating the ability of other independents to join the plan, even though they're willing to do it on the same terms. So it has that same kind of protectionist ring to it. And finally, with respect to mail orders, why the Department of Health said, well, consumers can opt out of the requirement for a mail order. Why should a consumer have to go to the time and expense, the trouble of opting out of a requirement for a mail order? Why shouldn't that just be permissible, that if a pharmacy stocks a particular drug, that the consumer has the choice? He can go to it if he wants, or she can go to it if she doesn't want and can use mail order. Again, this seems to be anti-competitive in the sense that it's designed to protect affiliated pharmacies that are really, which are really affiliated with the PBM in the mail order market. Thank you.
Thank you, Mr. Doyle, for your testimony. The last proponent is Deepak Kini.
Thank you, Madam Chair. Thank you for the opportunity and the great work you guys are doing for us. This bill is a patient choice bill, primarily. So to the first point about reimbursing based on patient outcomes, just because you have a gym membership doesn't mean you're going to lose weight or be healthy. What the PBMs are doing is throwing medications at these patients, and they say that this is when their pharmacies fill prescriptions every month because it's zero copay, the patients are more adherent. That doesn't even make sense, but they exploit the loophole to charge pharmacies a clawback. So they throw money through their own pharmacies, and we cannot do that because when they come to us, they have to pay a copay. So it's a ridiculous system that they're using a loophole to exploit independent pharmacies. Secondly, they've created this restricted network, like Jim said, where they've negotiated better pricing. So why are we not allowed to join that network? It's up to me and my patient. I have to take that hit on the reimbursement, but to retain my patient. So I'm willing to do that. Let me do it. I'm not a chain store, so I should be allowed to negotiate that into that restricted plan. So my thing is, mail order is the same as what Tom and Jim said. It should be a opt-in, not an opt-out plan. People should not be forced into mail order, especially in an urban setting where they just have to walk down the street to get to their pharmacy. Why do they need mail order? I'm going to take the same reimbursement as the mail order, so let me be part of that mail order. What's wrong with that? If they truly, like they said in the past testimony, all these PCMA and everybody, that they want to help independent pharmacies, let independent pharmacies into those restricted networks. Okay, you don't want other chain stores to come in because you don't want to dilute the network. That's fine, but let at least independents come in. That would be my thought, that let this be a patient choice bill and stop these PBMs from exploiting loopholes where patient outcomes only means filling more prescriptions. Filling more prescriptions doesn't ensure a good patient outcome. It is just a part of the process. So we understand our patients, we treat them better, we take care of them better. Let us take care of them and let us be the judge and let the patient be the judge where to go. Thank you for your time, and I hope you give a favorable response.
Thank you very much for your testimony. As we move to questions, I see we have a couple. I'm going to remind the committee of the question rules. One question, one answer, no follow-ups. Make sure your question is shorter than the answer. I gave you guys an inch last time and you took a mile, so now I'm going to be really strict in following those rules. First question to Delegate Morgan.
Whoever wants to answer it, the question, so the best person that can answer it. Do PBMs make money when they repackage a drug in mail order? Anybody want to take that one?
I honestly, I don't know.
I would say that's an anti-competitive practice. They're trying to retain all the profits within their own entity. They own the mail order, so they want to keep all the money to themselves. Yeah, I'll take a smaller hit and retain all the patients.
All right, thank you. Thank you, Madam Chair.
Absolutely. Delegate Johnson.
Thank you, Madam Chair, and thank you, panel, and whoever is best suited to answer this question. We're talking about having options on mail order. Can someone explain what the process is for a customer if their prescription is lost in the mail, and a ballpark time frame of how long it takes to work through that for the patient to actually get their medication?
We have anyone who wants to answer that?
Well, I'll try it. If people do come into my store and they say they haven't gotten their medication, can you help me? Well, first thing I do is I'll give them like 1 or 2 days to see if it does eventually get to them. After a couple of days, it doesn't come. I'll call the insurance company and see if I can get an override. If they give me an override, then they usually just give them like a 7-day amount. And if it doesn't come in 7 days, then I'll call again and they may or they may not give the patient medication. And I can only afford to give free medication up for a certain amount of time. And a lot of times these guys are just out of luck. They're just not going to get it.
Thank you, Madam Chair, and thank you.
Absolutely. I don't see any more questions. Just want to make sure everybody has a chance. Raise your hand if you have a question. Wonderful. We will move on to the unfavorable panel. Let's hear from Heather Cascone.
Thank you. I appreciate the opportunity. HB 819 provides a list of PBM practices that would be prohibited in the commercial market. First, the bill aims to prohibit spread pricing. There are essentially two basic approaches employers, or the plan sponsor purchaser, use to pay for services their PBM performs. They can use a risk mitigation, or as referred to here, a spread type of model, or a pass-through contracting model. A spread arrangement provides plan sponsors with cost predictability by giving a price certain for prescription drug reimbursement. Plan sponsors are the payer.
I'll ask the drafter tomorrow to write an amendment.
Hey, plan sponsors are the payer of the prescription drug benefit, and they have every opportunity to choose the pricing model that best suits their needs. Typically, they require PBMs to submit bids for both types of approaches. Some employers and other plan sponsors choose spread to ensure predictability in knowing what their drug costs will be. That choice should be theirs to make. Second, the bill would create an any willing provider scenario for pharmacies, something that Maryland doesn't have in any other aspect of the plan. Requiring plans to include any pharmacy in their network would increase costs for plans and patients. Opening networks to any willing provider laws reduces the volume of sales for all the network pharmacies, ultimately resulting in smaller discounts. That's because pharmacies agree to be in the network because they can count on a predictably higher volume of sales. Increased sales at the store mean that the pharmacy can pass those savings on to their patients while setting lower product prices and lower dispensing fees, while still meeting their bottom line. We have a lot of other concerns additionally regarding the amount of time for review of the network application, the removal of differential copays, changes to how PBMs offer mail. But given the amount of concerns on this bill, I will just respectfully request an ought not to pass, and happy to answer any questions about some of the mail issues that were brought up earlier.
Thank you for your testimony. Let's hear from Mike Johansson.
Thank you, Madam Chair. I'm Mike Johansson again on behalf of PCMA. We do oppose this bill. PBMs work for payers, whether it's the state health plan, a local school board, Care First with its small group market products or its exchange products. Many of you may have health insurance and have a PBM benefit. The PBM is not making a decision on whether mail order is offered, is incentivized, is restricted. The PBM doesn't make a decision on whether or not there's a narrow network or any pharmacy can participate in the network. The payer makes that decision. The payer makes that decision because the payer believes, on behalf of the people ultimately footing the bill, whether it's an employer, the state health plan, the Medicaid agency, the people that run the appropriations and the budget committees, when they look at what these costs are, the payers are the ones who decide which tools they want the PBM to use. And it's the PBM's job to offer up those tools in an effort to keep down prescription drug costs. Anybody can simply pay people more, and I would suggest to you, it's not going to hurt the PBM industry at all if that's what payers want to do. So bear in mind, when you see fiscal notes like you've seen, there are more costs in most of these other provisions that are here, including in spread pricing, including in any willing provider or any willing pharmacy. I'll note that there is no other comparable any willing provider statute in Maryland for doctors or anyone else. So the buck stops somewhere, and it's not at the PBM's footstep, it's at the payer's footstep or its enrollees who are typically sharing in the cost of that plan. So we encourage caution on all these issues.
Thank you very much for your testimony. Let's hear from Jennifer Bremen.
Good afternoon, Madam Chair, Madam Vice Chair, distinguished members of the committee. Thank you again for the opportunity to speak with you today. Again, I'm Jennifer Bremen. I come before you representing the Managed Care Organization Association. The association represents the 9 managed care organizations that serve the 1.3 million Marylanders enrolled in the Health Choice Program. The MCOs respectfully oppose House Bill 819. As you will read in our submitted written testimony, and as you all know, the MCOs are regulated by the Maryland Department of Health with a focus on ensuring high quality care and cost effectiveness. While we applaud the sponsors' efforts, access and quality provisions, including recently enacted regulations, were adopted by MDH to improve the experience of pharmacists in the Medicaid program. We believe that this legislation may undermine those processes recently adopted by MDH to address pharmacists' concerns regarding participation in the Health Choice Program. For these reasons, we respectfully urge an unfavorable report on House Bill 819. And again, thank you for the time and opportunity to testify today.
Thank you very much for your testimony. Let's hear from Matt Celentano.
Madam Chair, members of the committee, I am still Matt Celentano, and I'm still here on behalf of the League of Life and Health Insurers of Maryland and America's Health Insurance Plans, or AHIP. We are opposed to 819. This bill is fundamentally about a contract between a carrier and a PBM, and neither of which have asked for an intervention in this space. We would object to the removal of spread pricing. It is a tool carriers use to save money, and is an option in the absence of directly lowering the manufacturer's prices. Also in this bill, carriers are the only ones impacted by the spread pricing ban. Besides spread pricing, the bill also eliminates tools that carriers use to keep premiums as low as possible, including value-based purchasing, which is focusing on things that create the best healthcare outcomes, and any willing pharmacies, which drive costs. Some pharmacies are more competitive than others, and we want to be able to have that ability to work with those pharmacies to be able to keep the lowest prices possible, to pass on to the lowest premiums possible for consumers. As I think we've talked about a lot in this committee in the past couple of years, our prescription drug spend has exploded. It used to be about 10% of your total premium. It is now more than a third of the total premium, and we're doing the best we can to control these costs while list prices go up and up every year with no control seemingly from the manufacturer. This approach in 819 won't help, and we urge an unfavorable report. Thank you very much.
Thank you very much for your testimony. And the final witness of the day is Kimberly Robinson.
Oh, lucky me. Thank you, Madam Chair, members of the committee. Kimberly Robinson on behalf of Cigna, respectfully here in opposition to House Bill 819. It does a lot of things, and so it's not really possible to give fair address to all of the issues in 2 minutes. But I will say that one, on spread pricing, there's a mistaken belief that by banning spread pricing, it translates into higher reimbursement for pharmacists. That's not proven to be the case. In fact, if you look at states like West Virginia and Ohio, who have done it in their Medicaid program, while they did it for transparency, Secretary Cochran in Ohio was very clear that it did not bring down prices. And so there's a reason to do it, but that's not the one. And in this case, again, as Mr. Celentano said, it is a decision between only your commercial carriers and their PBMs, and the commercial carriers, of which I'm one, do not think that we need the state to make that ban on our behalf. Any willing pharmacy, there's a tremendous amount of discourse out there. If you were to Google it, you will find decades of studies that show that any willing provider laws do in fact increase costs. My first search hit came up when they looked at this for the Part D program, which found a 17% increase in premium would be likely. And for that program, being a large national program, would have resulted in $45.8 billion in expense over a 9-year period. And so we think that there's a reason to be really thoughtful about before implementing any willing provider laws. There's a reason why Maryland hasn't done so in the past. Because this bill is limited to your commercial market only, I just want to point out the fact that there seems to be some confusion about what Maryland already does. Maryland already has a law germane to mail order. Insurance Article Section 15805D2 already prohibits carriers in the state of Maryland from incentivizing the use of mail order. It's not an opt-in or an opt-out. It just simply says you can do it, but you can't make it more cost-effective for the consumer to pick it over something else. And that is already Maryland state law. I suspect The experience is one with ERISA plans, which this bill could not reach because this would be a benefit design. I have lots of facts for you all and details about the value of value-based reimbursement in pharmacy, but I don't have time to share it, and hopefully we'll get to do so at the subcommittee.
Thank you for your testimony. And as we have members raise questions for this panel, I will just make sure people know that as soon as we're done with this hearing, the chairman does have an announcement, so don't hang up right away. We have a question from Delegate Cullison.
Thank you, Madam Chair. This one is for still Matt Celentano. And you said that stopping spread pricing affects only the carriers. Can you explain that? Still on mute.
Sorry, Delegate Cullison, first time all day. It's the way I read it in the bill that it only applies to carriers. If you think that I am mistaken, I'd be happy to hear it, but that is my understanding.
Tell me how you think it works.
Matt, I think the question is whether or not it affects the pharmacy or only the carrier.
Right.
Yeah, right. I believe that is only the spread. Yeah, it's only in the insurance article. Spread pricing means a model of prescription drug pricing on page 2 on line 30. It is just between the purchaser of the contracted price for a prescription drug that differs from the amount of pharmacy benefit, and directly, it doesn't touch the PBM, from the pharmacy. Maybe I could be wrong. I will reread it and get back to you for sure.
But does it touch the PBM? That was my question.
I don't believe so.
Okay.
Sounds like something we can look at closer in subcommittee. Let's hear from Delegate Johnson.
Thank you, Madam Chair, and thank you, panel, whoever can answer. The senior population gets so confused over prescription drug options. So in your paid advertisements of putting out information, is there anywhere that you're letting them know that they can opt out of mail order?
Seniors that are enrolled in Medicare, I don't know what the rule is for that. Are we talking about our state employees plan? There's a different rule for that. Are we talking about Medicaid? There's a different rule for that.
For any plan that you're putting out advertisement and supposedly on information?
I think the type of information you're talking about, if it's related to the prior conversation, doesn't talk about mail order and specific benefit plans. It's every person's in an individual plan governed by a whole different set of rules. I'm sorry, I can't be more helpful.
Right. Okay, that's okay. All right. Thanks for your answer.
Thanks.
Thank you, Madam Chair.
Absolutely. I am not seeing any more. Oh, wait, Delegate Kipke has the last question. Delegate Kipke.
Thank you, Madam Chairman. Heather, I'm sure you're a lovely person, so I'm sorry that you're the one that I get to pick on, but you get paid the big bucks. So I've got a question for you. I brought up earlier this campaign, Affordable Pharmacy Action campaign that's funded by your organization. Now, you were a little dodgy when I asked you the question, but I'm going to forgive you for that. But it looks like you're taking out ads all around the country, on TV, on the internet, and blaming community pharmacies for the rise in costs. Now, the testimony is from community pharmacies that they're either losing money or barely breaking even. And I'm not going to ask you if you think that's true or false, because I know it's true. But what I'm curious about is, are your members, I know your association, for example, the CEO makes nearly $2 million, which is a pretty good salary for a nonprofit CEO. A lot of people make a lot of money there. But in terms of the PBMs that are in your network, are they making a reasonable profit? Are they one of the more lucrative entities within the healthcare arena?
Everyone in this prescription drug supply chain makes a profit. It's not a for-profit not-for-profit healthcare system. PBMs make one of the slimmest margins in terms of profit in the drug supply chain. You spoke to our campaign, and I just would like to reiterate that our campaign is not meant to defame or lie. It's an educational campaign. The independent pharmacy has a lobby as well, and they also have an agenda. And their agenda at this committee is to support bills that we believe will raise costs for consumers. We have pharmacy data that we believe conflicts with the information that they've put forth. And so we've shared that from an informational point of view.
Yeah, and just as a final note, some of your ads say by banning GER and DIR and these types of things where there's clarity in reimbursement, your ads say that increases the cost to consumers. Do you believe that's true? Do you think the actions that we've taken to provide clarity in what a pharmacy will actually receive increases costs to consumers?
Heather, you can answer that, but then that's the last, we're done. Thanks.
We've discussed GER and other types of blended reimbursement mechanisms in this committee on a whole host of different bills that have been proposed, specifically last session as well. We have had concerns with the way those policies have been drafted, that they could potentially raise costs. And so our messaging will continue to support that so long as we believe that that policy would have a negative impact on consumers.
Excellent. Thank you for your answer. That is the last question we have on this bill. And that concludes the hearing on House Bill 819. Thank you to everybody for your participation in these hearings.